Yes, ma'am, we are live.
Good evening, doctors. Thank you very much for joining today's webinar. And I'm Dr. Prachi. I welcome you all. So today we are bringing e-classic series for the clinicians, and today's topic is Caesarean section workshop. This workshop is brought to you by Warangal, Mahbub Nagar, Vizag, Vedudu Nagar, Tuticorin, Devangere, Khammam, and Tanjavur OBGY societies. I am very honored and proud to introduce our coordinators. Our coordinator is Dr. Apurva Asthana, ma'am. Ma'am is Director, Phoenix Healthcare, Greater Noida, and a visiting consultant, Apollo Cradle Hospital. Ma'am is also Treasurer of Society of Menstrual Disorder and Hygiene Management and Joint Secretary of Greater Noida OBGY Society, the recipient of many awards and special interest in high-risk pregnancy and infertility. Our next coordinator is Dr. Ayushi Agarwal ma'am. She did her residency from AIIMS Gorakhpur and currently junior consultant at Jeevan Jyoti Hospital and Medical Research Center, Gorakhpur. So I welcome you all and I hand over the sessions to Dr. Ayushi and Dr. Apurva. Thank you very much.
Good evening, everyone, and on behalf of all the organizers, I welcome you all to today's workshop, which is in the e-classic series for clinicians. The workshop today is on Caesarean sections, the rising incidence, the reasons for doing a Caesarean sections, the post-op complications, and how to tackle them. We all will agree that despite the restrictions faced by the government, despite the restrictions we face on ourselves, and despite the restrictions which have been imposed by the patients and their relatives, still the rates of Caesarean sections continue to increase. The global rate today is around 20%, and by 2030, it is estimated to rise to 30%. In today's workshop, we will emphasize upon the reasons to do the Caesarean sections, what are the complications, and how we can go about them. As the complications increase, so should be the learning. Today, we will emphasize upon the learning and the management of the common and the uncommon complications as well. To begin with, let us start in the name of God. Can we have a short prayer, please? We start by inviting upon our key organizer, Dr. Sadhana Gupta, madam. A pleasure and an honor to introduce our Foxy presidential candidate for the election year 2023. The co-chair CFOG NCT committee and Foxy representative to CFOG. She has also been a vice president of Foxy in the year 2016. मैडम के बारे में बोलना मतलब सूरज को दिया सा दिखाना है, तो मैं मैडम की और तारीफ क्या करूं. I will request ma'am to kindly speak a few words about the program and also introduce our guests.
Purva, thank you and a warm welcome to our all dignitaries and the societies of Warangal, Mahbub Nagar, Vizag, Virudnagar, Tuticorin, Devnagari, Khammam, Coimbatore. Special thanks to Dr. Madhu, Dr. Shisha from Warangal, Dr. Vijay Lakshmi Badami, Dr. Aparna from Mahbub Nagar, Dr. Sitaram Raju, Dr. Niharika from Vizag, Dr. Uman Maheshwari, Dr. Radha Venkatakam, Dr. from Virudnagar, Dr. Pumodi, and Dr. Jasmine from Tuticorin, Dr. Rashmi and Dr. Rashmi from Devnagari, Dr. Lakshmi Rajaswamy, Dr. Rihana Begum from Khammam, and Dr. Tamibani and Dr. J. Umar Dinda from Coimbatore Society. Because A big gratitude to all president and secretaries of societies, because it is all your effort and the cooperation and the coordination and a keen interest in always learning and sharing, so that we are together. A little bit about this e-classic for clinician. What is why we have coined this term, and it is around 60th the series of the e-classic for clinician. The two things that what we have learned from the teachers in that direction, that somehow our young generation is missing in very strong foundation of classic teaching. And this is the real difficult time when the knowledge is advancing at a very fast speed, but the human wisdom and the human conditions remains they change at a very slow speed. So how to amalgamate the knowledge with the basic concept of medicine? And the aim of all these series is that make every clinician, every OB-GYN of all generation very sound in the basic classical teaching, and include and involve the updated evidences, recommendation, and also the discussion and discourse. It is nothing about the following something blindly that some paper says and we follow blindly. We really invite the difference of opinion, their experience, because that is the thing which actually keep us going. So with this, and I'm being a gratitude that I have received the all cooperation and the contribution and involvement of all dignitaries, mentors, teachers, seniors, office bearers, as well as the members of the society. So today we will be focusing on intricacies and complexities of Caesarean section, which is a big issue. It is bringing bricks and the bouquet both to us, put a thing which is made a lot of implication, which we'll be discussing about it, about all the things. It seems we do day in and day out, but there are so many intricacies and complexities, and we really look forward with the great session, which is something very open-hearted sharing and the learning. With this, it is a great pleasure to have Dr. Nagaraj Shimoga for being his kind consent for being as a chief guest and gracing this webinar. We have met so many times to the sir, and he is being with him is something a great learning, a very quiet and a very knowledgeable person. We see him as a father figure all over the country and the Kasoga. Dr. H. Nagaraj, who is the practicing OB-GYN since 50 odd years, patron Kasoga, and we have witnessed, because I have been in many programs in the last few years with the Kasoga in Tumkur, in Hubli, Dharwad, and Sir is actually loved and adored and respected by all the OB-GYN across the country and of course Karnataka. Founder President of Kasoga, so Sir leaves a legacy. What we say, the great people leave the legacy. And this is the thing which we learned from the great people. Founder President of the Shimoga OB-GYN Society, former President IMA Shimoga, involved in various organizations, including Doctor Housing Cooperative Society, that speaks volume about it. Balan, the Melnad Cancer Hospital, and the Shushruta Biomedical Management is run by doctors only, first of its kind. So you see, this short CV speaks volume about Sir, about Dr. Nagaraj, who is having the futuristic and responding to the present challenges, finding solution for it. And this is something which we learned from our mentors and organized to Kasoga State Conference. And of course, he is the anchor figure for the Kasoga. A warm welcome, Dr. Nagaraj. Once again, gratitude, and we look forward to listening from you for the pulse of wisdom. So I think you can stop screen share so that we can listen to sir. Stop screen share so that we can listen.
Good evening to all.
Stop the screen share. Yes, ma'am. Yes.
I would like to thank the organizers for the opportunity for a student of obstetrics and gynecology who is practicing in a semi-urban area. I am a very small person in front of you all. Just I am practicing in a semi-urban area. I want to learn many things from even now. Now the knowledge is in has to be spread for all the societies. And today you have chosen a topic, a common topic, Caesarean section. It is complications, indications, Robson classification, and all the complications, then medical legal issues also. I would like to thank Dr. Sarnath Gupta, key organizers, guest of honor, Dr. Revati Janki Raman, Professor Vidya Tabbe, President Kasogan, and all the dignitaries involved in this webinar. Today we are discussing the important topic, Caesarean section, its indications, Robson classifications, technique, prevention of scar defect and complications, post-Caesarean section care and its complication. As you are aware, it is one of the most common procedure in obstetrics. I now I can tell that I have done a few classical Caesarean sections in my early career in late 60s. Probably nobody does it except in cases of placenta accreta syndrome. General surgeons used to perform classical Caesarean sections in earlier where there was no obstetricians. We have to address the rising trend, complications from Caesarean section, scar pregnancies, isthmocele, placenta accreta syndrome, medical legal issues also. Now the trend of PABC is diminishing. It is not at all discussed even in conferences. I can say that in a 50% of cases, I have given a VBAC and succeeded in VBACs. But unfortunately, nobody is willing to practice VBAC nowadays. That's my feeling. I would like to wish the good luck for Dr. Sarnath Gupta, the presidential candidate, Foxy. I am sure she will be the winner and continue to work for the Foxy. And I know she is traveling length and breadth of all over India and campaign. I wish her good luck. Thank you for the opportunity.
Thank you, sir, your precious words of wisdom and your precious blessings, which means a lot for us. It is invaluable for me. And we will always, like, we are committed to women health and healthy India, and focusing on the special reasons, and especially we have to, like what we say, what you have said about the small places, small cities where we have to have that, the excellence and the wisdom everywhere. So thank you, sir, for your gracious presence. And we have a fortune to have a very, very old friend, very close friend, Dr. Revati Janki Raman, with us. And Dr. Revati, we had a close association. We were the vice president of the Foxy together. So we had a both simple and the dedicated person we were, and we enjoyed our tenure a lot. So please, yes. So thank you, Revati, for being with us. She is former director of the IOG Chennai, Vice President Foxy, yes, 2016, and the President TNFOG 2023. Founder Secretary and past President of Madurai OB-GYN Society, Founder President IMS Madurai Menopause Society, President Madurai Chapter of the PSAR, recipient of Foxy Dr. Durusha Community Award. She is known for her exemplary community services, a Lifetime Achievement Award by IMA Madurai, and a Master Trainer for PPIUCD program by FIGO Foxy. Author of Foxy Focus Amniotic Fluid A to Z in 2016, she published, contributed many chapters, a great academic writer and a great academician, and the pride of Foxy Award. Yes, you are pride of every organization, Revati, and it is really blessings to have the persons like Dr. Nagaraj, Dr. Revati in the journey when we really serve selflessly for our federation. It is really blessings to have gems of persons in our life. So we look forward to your words, Dr. Revati.
Thank you, Dr. Sadhana, for your kind words, and also thank you for inviting me as chief guest today. Good evening, dear friends. The hot topic everywhere today is how to bring down the cesarean section rate. No doubt, there is an inevitable rise compared to the past. Choosing the proper indications and audit will certainly help to avoid unnecessary C-section. And this part is going to be dealt with by my dear friend, Dr. Vidya Tovi today. Relearning the art of vaginal delivery is very, very crucial. You know, present generation, they have gained a lot of confidence in doing cesarean section, right and left. They can do it easily, even without any assistance, without staff, anything they can do. That much of confidence they have gained. But unfortunately, they have lost that confidence in conducting a normal vaginal delivery. This part should be taken care right from student days itself in teaching institutions. Actually, in our Madurai Government Rajaji Hospital, the big hospital here, in I think January or February, the whole month, there was no cesarean section at all. And that was flashed as a hot news. Now, one more important complaint that is put forth is CS rate is more in private setup. Now, instead of randomly putting the blame, we have to analyze through audit before coming to a definitive conclusion. Patient willingness, motivation for vaginal delivery, all these things are very, very important. Also, doctors' inclination to go for it. Now, actually, recently I had 2 cases, one IVF pregnancy and other recurrent pregnancy loss, 3 or 4 mid-trimester losses. Both are very particular, they're keen about vaginal delivery only. But otherwise, there is no other complication. Normally, in such situations, either an elective section is decided or cesarean section for a flimsy indication is done. But with patient cooperation and close monitoring, both of them delivered beautifully vaginally, 3.5 and 3.8 kg baby. Now, not only the immediate, but also long-term complications of CS also should be taken care of, which is going to be dealt by Dr. Sadhana and post-operative care by Dr. Niranjana. And there is another panel of handling difficult situations, C-section, moderated by Dr. Padmaja. Now, I'm sure at the end of the day, you will all go with a lot of take-home points, which you can make use of in your day-to-day practice. Now, before I conclude, I request all our friends to vote for my dear friend and co-VP 2016, Dr. Sadhana Gupta, who is contesting for Foxy President this year. And I wish you all the best, Dr. Sadhana. And the whole Tamil Nadu is behind you. And I also wish this webinar a grand success. Thank you very much.
Thank you, Dr. Revati, for a real thing, and that no cesarean section for whole month, and that is in a big hospital. That is a news. That is a news which must draw attention, and all your experiences about VBAC and everything which we have to actually review in our clinical practices and the protocols, and above all your being always in life together. We have been, and all your precious wishes, which is a very, very important thing for me, because the blessings and the wishes from friends means a lot for us. So thank you, Revati, and thank you, Dr. Nagaraj.
So can we start with the scientific session, ma'am?
Yes. So, Apurva, with the permission, should
Yes, ma'am.
yes, so we have all the chairpersons, because the first talk is there. So I think we will go. We will go with the same.
Yes.
We will. Yes.
So with the permission of our guest of honor and chief guest, can we start with the scientific sessions? Okay. So the first session is about cesarean section technique to prevent scar defect and its complication. To chair the session, we have Dr. V. Sitaramaraju, who is the president of OVGS. He has worked in Jipmer Pondicherry as a senior resident, and he is in private practice from the year 1990. Presently, he is the president of Obs and Gynae Society of Visakhapatnam. Attended a number of workshops and CMEs, and was also selected as a WHO fellow in 1998. We welcome you, sir. I think Dr. Sir has not joined, Dr. Niharika, right?
Yes.
Sir could not join. Next, we have the second chairperson with us, Dr. Niharika Allu. Madam is a consultant OBGY at Birthright by Rainbow Hospitals, Visakhapatnam. She is presently the secretary of OGSV and has been the joint secretary of the same association. Has contributed a number of chapters and a gold medalist in her post-graduation. We welcome you, Dr. Niharika, as our chairperson.
Thank you, Dr. Apurva.
Our next chairperson for today is Dr. G. Radhalakshmi. She is a director of Prasanna IVF Center at Srivilliputtur, Tamil Nadu, has done a number of fellowships in embryology and ART. We welcome Dr. G. Radhalakshmi also. Welcome you, ma'am.
Thank you, ma'am.
I will request Dr. Niharika to kindly introduce our speaker for today, Dr. Sadhana Gupta, ma'am.
Thank you, Dr. Apurva. At the outset, I would like to thank Dr. Sadhana Gupta for this opportunity, and I bring greetings from the City of Destiny and the Obstetrics and Gynecological Society of Visakhapatnam. I regret that our president could not join on this webinar. I've been watching these e-classics series whenever, I've been getting these forwards for e-classics series per Caesarean section workshop, and we were wondering when it will be our turn. So we are very, very glad to be associated with you, Dr. Sadhana. And I personally have had a lot of occasion to meet you during all the conferences, and we have been chairpersons together very recently in Foxy Figo. So I would like to introduce Dr. Sadhana Gupta. So she is our presidential candidate for 2023. She was a co-chair at SAFOG NCD committee and a Foxy representative to SAFOG from 2018 to 21. She was the Vice President Foxy in 2016 and ICOG Governing Council member with Best Governing Council Award in 2021. She's the corresponding national editor and peer reviewer for Jogi and the Journal of SAFOG. And she's been a Foxy past chairperson for Foxy Safe Motherhood Committee with Foxy Dr. Mehrud Dara Hansotia Award for Best Committee Activity. She has many, many, many awards to her credit. She has a lot of research papers. She's worked in key organizations, and she's worked for a lot of conferences. So I think the list is endless. And despite so many achievements and being such an eminent speaker, I've always found that she is a very, very humble and down-to-earth person with a smile always on her face. I wish her all the best for her election campaign and for the elections. And I welcome you, madam, to talk us through, the steps of cesarean section technique to prevent the scar defects and complications, and to how to avoid problems in the future pregnancies, so we can give a vaginal birth after C-section in most of our pregnancies. Welcome, madam.
Thank you, Niharika, for a loving introduction. And it is, we have been really together and shared many, many sessions. And we are very happy that we are today having this workshop with you. So my regards to Niharika, Dr. Radhalakshmi, and President Visakhapatnam, who is might be joining just now. So I will be in my talk, actually, I will be taking 2 or 3 things simultaneously, what the new understanding we have got about the cesarean scar healing and the scar, the status of the scar, how we really have the sometime life-threatening and sometime mild cesarean scar complication immediately, and a need for the standardization of cesarean section along with the flexibility as per the need is there. So it will be a little different topic and the amalgamation of few challenges, and we will like to have the discussion after that for the chairperson and from the August members. So a big gratitude for always being together. These are few my recent visits. I was in Madurai with Meenakshi Temple, then the Chennai, and it is Rangnathji Mandir, and the South is something where we really have what Niharika says, people are very, very the strong academician, a very wise clinician, and actually South have much more to give to Pan India about their sharing their expertise, experience, and we must have in our federation all inclusive and all representative face, because the maternal and child health indicator what we have achieved in South. So Southern societies have to give much more to the Pan India and across the India experience. So I bring greeting from land of Buddha, and he says we can never obtain peace in the outer world until we make peace with ourselves. So today, when there are so much of noises about everything, be it cesarean section, be it a maternal criticality, be it a social media, so many things we are having. This is the very important thing, that at the core of our heart and mind, we remain peaceful, because as a doctor, we have to give the peace and compassion to our patient. So cesarean section is a unique surgery for society and civilization, involving two lives and avoiding, that is a bypassing the most important and difficult journey of human being, and it is done for the physiological reason. Most commonly abdominal surgery performed, and the important thing is that the cesarean section status is always in the background of what is happening in society, what is women empowerment. So we have come a long way from the last attempt to save mother's life to the huge demand of the cesarean section on maternal request. So this is, it is not a thing which we can do in isolation. And what we say, always we have a lot of hue and cry, because now we are so much connected that we really have to be very focused and looking actually how the things are. So WHO, it was 1985 statement when WHO says that the cesarean section rate should be 15%, and more than it does not improve the perinatal issues, perinatal health. But the FOXI as well as the WHO have actually revised the statement and say that we should not run after any rate or something. Any woman who have the right to have a expectation of a successful and safe vaginal delivery, but whenever she needs, she must have the access to a good quality cesarean delivery. So this is the both statement, and this is very important, that overall, Revati just said that no cesarean in 1 month. Overall, still our country's cesarean section rate is not more than 20%. So we have to be a little bit firm about all these media things. Repercussion, but still why we are really worried about that a little higher increase cesarean section in the private sector for the IVF pregnancy, because we are having backlash of increased cesarean. Economic cost, we have still the more maternal morbidity and mortality after cesarean section, perinatal morbidity like iatrogenic prematurity, long-term neonatal health issue, and what is really troubling is the cesarean scar defect and all spectrum of the cesarean scar complication. We are really don't know that how come the cesarean scar pregnancy placenta accreta syndrome is coming day in and day out around us very silently, and suddenly we face the life-threatening situation. And all diagnostic and management modalities still is not RCT. It is not a very like a large studies. It is always experience based. So question is that can we prevent this life-threatening emerging cause of the maternal criticality and the mortality? So one thing, the cesarean section should always remain just cesarean section. Vidya must be coming like a little bit later, that she will really focus that how important to review every indication, because these are all new paper from our country, from our regional country, that we are having all these the incidents of re-laparoscopy, peritonitis infection after cesarean section, and we have to be very careful about indication. So surgical site infection, because it is a surgery, so it has got its own inherent issue. And one thing is that the risk assessment is the key for obstetrical management. So risk assessment for the infection is also very important. It was a prolonged labor, referred patient, anemic patient, patient with obesity, patient with GDM, and we know that we can have a mild degree of infection, we can have a severe degree of infection like necrotizing fasciitis. Yes, wound swab culture sensitivity, good dressing. If it's sometime it is like a debridement of the necrosed tissue. And this is the thing what we want to achieve. That is the prevention of surgical site infection. We don't want any sort of infection in our patient after cesarean section. And one or two thing is the prophylactic IV antibiotic. IV antibiotic we are giving, what I want to emphasize that it should be given around 30 to 60 minutes before skin incision. So it is not so 3 or 4 surgeries are there, so that nurses are given 2 hours before. It must be around when the anesthetist is giving regional or spinal, and it is not to be deferred after delivery of the baby. For low risk cases, it is single shot or the for period of 24 hours. But if you have high risk situation like the like the diabetes, obesity, something complicated surgery, it is fairly okay that we continue the antibiotic for 5 days. We can have any second generation cephalosporin or empigentametrogel, which is many times available in public health setting. So this is very important, and we cannot go away with the universal safety precaution, not only in our cesarean section OT, but in our labor room, most importantly. And this is because here is the thing where the infection actually comes. Postpartum uterine dehiscence is something they present to us as a recurrent postpartum hemorrhage, which is unexplained, which is we are not able to have anything related to what is the cause or imaging. And patient may present as early as 10 days to 12 weeks after surgery, and sometimes the chronic abdominal pain there is. So one thing I wish to say that when there is an unexplained secondary postpartum hemorrhage, look for few things, which is the red flag sign for the uterine dehiscence. That is the presence of bladder flap hematoma more than 5 centimeters, any hematoma which is pelvis in the pelvis, presence of gas from the endometrial cavity to the perimetrium, and these are the red flag signs. And this can be the life-threatening situation. And infection itself also can cause the postpartum uterine dehiscence. So this is important thing that we must be aware of it. And cesarean scar defect, which I will be touching in detail because it is not that uncommon entity. Now we are having a color Doppler so frequently that so many times everyone says this is a AV malformation and patient might bleed very much. So one important thing is that yes, there can be pseudo aneurysm of the uterine vessel, and there can be the AV malformation. But important thing is that when we diagnose, be careful that we diagnose right with a good color Doppler setting, gain setting. It is a yin and yang. It is a turbulent flow which is flowing, and this is how we deal with diagnose pseudoaneurysm. And when there is a stable patient, you can go for the embolization, which is unstable. Sometimes we really need hysterectomy. So long-term scar complication, scar dehiscence, that is scar defect is the thing, because our defense is weak, then everything will be invading to us. Thief will come to us, dacoit will come to us, and that cause the all scar pregnancy complication, which can be the full this is spectrum of the placenta accreta spectrum. So this is one thing what we have, we have to be aware and how it looks. And it is a good research point that after 12 weeks, you call the patient for the ultrasound and you see that what are the findings of the scar niche, so that the patient as well as you are aware what you are doing in the cesarean section technique. And if she becomes pregnant, or if she take medical abortion, or she comes to MTP, you are aware that her scar is having certain deficiency. Of course, beside the surgical section technique and the timing, it is always a genetic predisposition. We see sometimes they have the antecedent like propensity for the poor wound healing, and all the things are related to genetics nowadays. And sometimes that is they show the hyper-invasiveness. What we say, when our wall is weak, then everything from a small bypass person to the thief, everyone will come to us and invade us. So many names we call for the scar defect: isthmocele cesarean scar defect, dehiscence diverticulum. And how you see transvaginal sonography and sonohistography are the thing. We don't need any very costly investigation, just you have to be aware. And it can be around 30 to 50% of the women after cesarean section. More number of cesarean section, more prevalence of the scar niche. The risk factor can be surgery related and the patient related, and this is when there is a normal scar, it is just hypoechoic indentation. But when there is a scar defect, you will find a regular hypoechoic shadow. And the second important thing, one is the size of the scar defect. Second is the residual myometrial thickness, which actually sets the stage what Revati was saying, that VBAC. So that residual myometrial thickness is also very important. Risk factor can be adhesion, retroflexion of the uterus, patient factor, GDM, previous cesarean section, high BMI. And very, very important thing is that longer active labor prior to emergency C-section, as well as the elective cesarean section much before the term. Both have the more chances for the scar defect because we are not placing the uterine incision at the right place. So this is one of the very, very important message I wish to say, that if we do cesarean section in advanced labor, incision might be in cervical tissue, which result into poor tissue healing. And it is better that even when we are planning cesarean section, we do closest to the term or maybe a little bit with the onset of the labor. We don't do it very late and we don't do it very early. Retroflex uterus, because it is retroflex, so the blood supply to the uterine wound is less, it is counter current pressure. Likewise, adhesion, which can cause the poor wound healing, also lead to the cesarean scar defect. Other risk factor, more maternal age, more number of cesarean section, more number of induced abortion. Because actually, whatever injury we instill to the endometrium cavity, it can cause more and more. And we have to be a little careful, in my mind, that the patient, the women who are taking multiple dose of the medical abortion drug, can it also cause us some sort of problem? So this is something to the thought process. And a very good paper from the China who says that the cesarean section done at the rural community hospital is found to be the independent factor for the cesarean scar pregnancy. So this is very, very important thing, because our government actually like says in every setting that you do cesarean section, obstetrician is not there, sometime MBBS doctor or the general surgeon, infrastructure is not there, but the suboptimal quality can also lead to the scar dehiscence and all scar pregnancy. And many times the senior people say, even sometimes I say that in my cesarean section, there is no placenta partita is something. So a little bit about the infrastructure. So non-modifiable risk for the cesarean scar defect, age, retroverted uterus, we cannot change. But what we can change, the timing of cesarean section and the surgical technique. And the important thing is that the right place of cesarean section, if we exclude endometrium during repair, now it is a teaching that we should include the decidua in the thickness, and the single layer closure is also related to the very, very important thing which related to the scar defect. How they can present to you in the gynae's OPD also, sometimes asymptomatic, you just see no symptom. Abnormal uterine bleeding is very, very important presentation, because there is a niche so obstructed, there is a obstruction in menstrual blood flow, then it is slowly released with the pain. So that is a abnormal uterine bleeding with chronic pelvic pain. She comes to you many times, we think it is a endometriosis, which we are not able to have the like a finding, ultrasound finding. Be careful in previous cesarean 1 or 2 or 3. If she is coming with chronic pelvic pain, does the patient has the scar niche also. Secondary infertility is the thing, patient can have secondary infertility. If you are doing IVF, a very, very difficult embryo transfer, virtually you are not able to put the embryo at the right place, bladder dysfunction and the scar abscess. If this scar defect will be the bed for scar dehiscence, uterine rupture in subsequent pregnancy, as well as the placenta accreta syndrome. So these are a few very, very good papers from our own country, Vidushi from AIMS, then the Rosa, like many good papers. And a very good paper from Indranil Datta, why I'm like really emphasizing that the patient doesn't, we are missing all these things. And how we get the patient, she has taken medical abortion like a 10 days or a 1 month ago, she is coming with recurrent bleeding. You do suction evacuation and you see a lot like a life-threatening hemorrhage. So these are the collection of the case situation from our own Indranil Datta, that how we are actually facing an average OB-GYN, suddenly the life-threatening situation. So this is just the transvaginal sonography. The sonohistography is fair enough for the diagnosis in most of the cases. Very, very rarely you need MRI, which I don't think that it is needed in many, like very, very few unexplained situations. And always look for the residual myometrial thickness. So if it is less than 3 millimeter, then it is a significant thing. It can have inward protrusion, outward protrusion, concavity, abnormal vascularity. Sometimes it can look like a polyp also. So these are the few images that is the most you see. It is a sonohysterography image. You have put the catheter and you see that the fluid is going into the scar niche, and the residual myometrium, you can actually measure that it is less than 2 millimeter. Not every scar niche need asymptomatic woman does not need management, but if it is AUB, you can go for the COC. And LNG IUCD is not found to be effective, but if it is causing chronic pain, secondary infertility, a symptom for the IUB which is not responding, then hysteroscopic resection. If it is low down, and hysteroscopic niche resection with isthmoplasty, and sometimes it is hysterectomy also. So Dr. Alka Kriplani, a renowned endoscopic surgeon, and our vice president, Mayan Repti, president, has a very, very good collection of these niche repair, and she is not having that less number, a big scar niche she is treating. So coming to how to prevent, so primary prevention, primary cesarean section, and secondary prevention is a good surgical technique. So Shahidi, please unmute the person. Shahidi, please see that who is mute. So right timing of labor and the level of uterine incision. So this is very, very important, that if you give the incision towards the cervix, it will result into poor healing because mucus interfere with the gland and with the myometrium. That secretion interfere with the myometrial approximation. So this is, again, I emphasize that when they take the discharge slip, we take the like a indication. But now this is a point of thought process that in our discharge slip, we say that at what gestational age cesarean section was done, and it was in the labor, or it was in the second stage of labor, or it was at the 37 week, because that gives you idea that this patient is having more chance of the cesarean niche. So these are the things, and with this background, this is Dr. Atul Gwade, a wonderful person and a medical fiction writer. So I think I'm really fond of going through all the literature which have been written by doctors. It may be Atul Gwade, it may be Chekhov. If the younger generation know that the Chekhov was a doctor and what a classical writer he was, because we understand ourselves. Complication checklist, it shows that we mortals, it gives you insight about our own mind, how surgeons behave when there is a complication, how we do the things, and it is something, a very, very interesting thing to know, and actually it gives you deep insight that how we should be dealing with our patients. So why the problem for the standardization of the cesarean section technique? Because we are having thousands of papers, and it is not a very uncommon scenario that in different unit, the different heads have a different way of the closing. Few people are always say, we always go for the single layer, though the evidence does not support. So many things are there. And there is a strong argument for the standardization of cesarean section technique, because the most common surgery, around millions of babies are born through cesarean section, and this is the only surgery where the standardization of cervical cesarean technique is a public health issue. So this is important because only the third year resident teaching second year teaching first year, and we actually don't know that how careful they are. So this is a very, very important. So basic technique as a OB-GYN, we know that how we do, and it is pictures from my own book, Step by Step Cesarean Delivery. I will just like to have a quick recap. The transfer incision 2 to 3 centimeter above pubic symphysis. What is the recommended thing? What should be the standard? In a non-complicated thing, sharp subcutaneous fascia dissection and expansion is a blunt peritoneal entry. So we just like with the hands, we can open the just at the virgin space. Bladder flap development, usually it is indicated, and the incision site is very important. That is the 2 to 3 centimeter transverse uterine incision, blunt entry, and cephalad followed expansion. No MRP to be done in cesarean section, no intrauterine wiping. We sometimes, the junior people, because out of their insecurity that the patient might bleed, so they go on like wiping again and again. That causes the weak scar as well as the infection. No routine cervical dilatation, even in the elective cesarean section. Uterine acceleration is recommended actually. And the very, very important message is the double layer non-locking suture with delayed absorbable suture. Omit any abdominal irrigation, omit visceral peritoneal closure, omit rectus muscle approximation, omit routine glove change. Rectus sheath continuous closure with delayed absorbance, so no need of locking. Subcutaneous tissue only when it is more than 2 to 3 centimeter, and we can use staple subcuticular or absorbable monofilament. So externalization has been found safer thing. So many people really say that we never do the externalization, but actually we have to be flexible with both technique, because when the atonic uterus is there, when you want to see the posterior hematoma, when you want to have the massage or any extra procedure, the externalization of the uterus have been found safer without any increased way of time. And this is the new paper, what is the Lewis and 2020, that when we have the externalized uterine repair, we have less blood loss and a shorter operative time. Double layer closure non-locking suture is the thing which actually gives us the good residual micrometrial thickness and a good approximation of the wound. All papers say very, very strongly. So this message I wish to give, that again and again the study shows that the double layer closure is result in higher residual myometrial thickness compared with single layer closure, and single layer closure has been associated with increased prevalence of the isthmosis. So these are all new studies which I just say to have your confidence in this. So this is important. And the another thing is the muscular edges are thing they are best approximated by including deeper part of the layer and the remaining superficial in the second layer. Non-perpendicular suture leading to irregular myometrium closure. If there are locking very tight second layer suture, it can cause the ischemic necrosis and again result into the poor healed tissue. Always basic principle of surgery, no unnecessary tissue manipulation, no devasculation, tissue ischemia. So we have to say one or two things. The technique has been proposed to prevent that scar defect. So this is neither Joel Cohen nor Fenesteel. You just follow the maternal abdominal crease, give the extension like the size of the incision as per the baby size head, and the closure of uterus is a little bit different. That is a 2 continuous suture which are then knotted together, resulting in short double layer closure. So these are few images which have been proposed. I don't say that it is a standard technique, but the person in the teaching institution can actually have some time experience of this. And this is another technique have been proposed that by the visual, that you give the 2 loops. So it both way it is a 2 layer, but the technique is different, so that it takes almost the same time as the single layer. So you give caudal to cephalic, you tight. So in one go you have the double layer suturing, and the author says that it gives more myometrial to myometrium, endometrium to endometrium, good approximation. So finally, the surgeons as a group adhere to curious egalitarianism. We believe in practice, not talent. So we know there is no substitute for the experience. So be aware of the cesarean scar indication, cesarean indication, a good surgical technique, from the timing, from the antibiotic prophylaxis to the putting the incision and closing the incidence. And we have to work together for the standardization of the cesarean scar technique. As a teacher, we always say that the teacher handhold the juniors how to do, and like taking care of very, very small thing, and that the teacher-student relationship we have to maintain in our country. So world has not become too complex for simple answers. You see, the simple thing matter most for us, and this is time what Niharika says, that we as a simple person, all Southern people, we are so simple in living and in our thought process, but we are so much dedicated to subject, dedicated to patient, dedicated to the like the people around us. And I seek everybody's full-hearted support, and voting is just going to start after 5 days. Please do vote and support. Ask your all friends to vote for me, because it is real time that a simple, dedicated, and a committed person lead the organization. So thank you once again for the opportunity to being together. Thank you.
A wonderful talk, ma'am. Thank you so much. And I will request our chairperson, Dr. Radha Lakshmi, to kindly summarize the talk. Ma'am, please unmute.
Hi, Vidya. Good evening.
Audible, madam. Audible, madam. Thank you for the wonderful opportunity, madam. I am a very small person in front of Sadhana madam and Revati madam, my professor. So Sadhana madam has taken a very elaborate, simple and take-home messages right from the indication and right place of uterine incision and the importance of induced abortion history. And we come across a lot of difficult embryo transfers in previous Caesarean cases. So how that is important, how to evaluate, and the niche, and including that sonohysterography and niche resection and esmoplasty. So thank you, ma'am. Thank you for the wonderful session, ma'am.
Niharika, you want to say something? Because thank you, Dr. Radha, for your nice comment. Niharika, you want to add something? Or
Madam, one doubt, madam, that regarding the right place of uterine incision, you told, madam. So for the beginners, how will you say that is from the UV fold, how much distance you have to open cesarean section?
Actually, it is just the bladder retraction. What I actually emphasize, that if we do a cesarean section before term, sometimes it is not elective, it is not indicated, then we tend to put the incision at the higher place, and then we don't have a good approximation. Likewise, when we do, always we are worried, na second stage cesarean is not good, it is like a very difficult. Then we put the cesarean section scar, we tend to have a lower down incision, and then the cervical gland mucus interfere into the approximation. So say if there is no emergency, or if there is nothing like no further, like just because for the sake of convenience for us and that the patient does not come into the night, we sometimes do just at 37 weeks. It is better that then we find actually automatically the right place to give the incision. That is optimal. So it is nothing about it. It is the same. You give the incision, you retract the bladder, and bladder retraction is something because many people are, so they say no need of bladder retraction, you just give the incision, but majority of situation actually we really need that. So my takeaways was that correct, like a better timing is close to term or with the spontaneous onset of labor. And of course, we always second stage cesarean section is a difficult. So it is not something measurement, it is about the inadvertent putting the incision either above or much below.
Madam, another thing, in case of bleeders, after this, after closing of the uterine incision, we'll be having some bleeding now. So do you prefer to transversely ligate, or you use bipolar to catch the bleeders?
Actually, I think we will be dealing these case situations in the panel as well. But important thing, if there is small oozer, then we cautery a little bit. But when there is a sputter or something, we have to ligate. So usually it happens, it's simple cautery, usually it's done. Only the selective uterine devascularization, like when going to have the uterine artery ligation, when there is a really trouble, either atonic postpartum hemorrhage, or it is not at the uterine surface, it is the placental bed bleeding. Before closing the abdomen, we are finding that the placental bed is bleeding, not responding to oxytocin, tranexamic acid, oxytocin. Then we go to the other thing. So it is all about flexibility. I hope that there will be the discussion in all these situations in the panel discussion as well.
I would like to add one point. For youngsters, they want to be a fast surgeon, want to finish out so soon. So they don't want to mobilize the bladder. They want to go for a single layer suture and hurry up. And remember one thing, time is not at all a matter. Quality is more important. So that they have to remember.
Very important. Somehow it is in the OB-GYN, always a competition. If she does that in the 15 minutes, she does in the 20 minutes. So actually, you take your time of the hemostasis. It is not that you unduly handle, manipulate that issue. This is not needed, but you have to take the time. Just giving the incision and the uterus is dextrorotated because it is hurry, not putting like finding the thin space in the peritoneum and just be and like injure her bladder and sometimes bowel as well. So very, very rightly says a teachers like a Dr. Repti is a teacher, like this competitive thing has to be go out of our mind and the good technique. So thank you, Repti. Thank you.
Thank you. Thank you. Wonderful talk, Sadhana. Thank you.
Thank you, Dr. Sadhana, for the wonderful talk. We enjoyed it thoroughly, and I think you've summed up everything. And as Dr. Revati ma'am said, everything has to be standardized, but you have to develop your own technique with your own experience. You know when it is right, when it is wrong. You have to develop your own technique. Thank you, ma'am. Dr. Apurva, can I hand over to you?
Yes. Thank you so much, Sadhana madam, for those pearls of wisdom. Actually, there is no substitute for experience and there is no substitute for hard work. With that in mind, from the per-op technique, we move over to the post-op complications. The speaker for today will be Dr. Niranjana, and to chair the session we have
Apurva, Dr. Vidya has joined.
Okay, ma'am. So can we take her talk before?
Dr. Vidya, I hope so, yes. Because it is
I have joined, but I'm traveling. Hello, am I audible?
Yes, ma'am.
Yes.
I have joined, I'm traveling, but I have already shared my PPT. So if I'm audible, I can talk also, no problem. Am I audible, Sadhana ji?
Yes, you are audible. So if you think you are okay when you reach home, then we will have the Niranjana talk.
Yes. But it will take time. It will take time. I'll just let her speak. After that, I can talk too. Okay.
So Niranjana talks, na? We can have.
Let Niranjana talk.
Yes.
Okay. So to chair the session, we have Dr. Doris Anson with her. She is presently the consultant at AVM Hospital, Tuticorin, has completed her MD from Kilpauk Medical College, has been the past secretary of Tuticorin OBGYN Society and is the president of the same. With her field of interest in high-risk pregnancy and laparoscopic surgery, we welcome you, ma'am. The second one we have with us is Dr. Vijay Kumar. Sir is a medical director of Srushti Speciality Hospital, Davangere, and is the secretary of Davangere OBGYN Society. Sir has got a special interest in incontinence surgeries, VVF and UVF surgeries, and in pelvic reconstruction. He is the assistant professor at Shimoga Institute of Medical Sciences and has been the associate professor at SS Institute of Medical Sciences as well. We welcome you, sir. Our next chairperson is Dr. N.R. Devarkar, who has done his post-graduation from KMC Mangalore and has been the consultant gynecology at Santi Speciality Hospital, Kodakara. He has worked as consultant at Holy Cross Hospital, Chikamagalur, and presently working in Department of OBGYN at JJM Medical College. Welcome, Dr. Devarkar. I will request our chairperson to kindly introduce our speaker for today, Dr. Niranjana.
Ma'am, shall I do it?
Yes, please.
I bring greetings from Tuticorin Fair City, Southern India. Good evening all. Good evening, Sadhana Gupta ma'am. Happy to be associated with this webinar. I'm happy to introduce Dr. Niranjana Ashokan, Assistant Professor, Panimalad Medical College. She is known for her awards, Dr. Amarendra Nath Prize, AACOG 2019, and Mangalam Kasirajan Gold Medalist, Oxycon 2020, and Dr. C.S. Dawn Prize, AACOG 2022. We are happy to have you here, ma'am, on post-operative complications. Welcome.
Thank you so much for the kind introduction.
Dr. Ranjana, you're not audible properly.
Fine. Okay. Ma'am, is it audible now, ma'am?
Yes, yes.
Okay. So the topic given to me is post-cesarean care and complications. Cesarean is a very common surgery that is being done now. We do it for various indications, maternal, obstetric causes, because now most women want to conceive at a later age. And so the associated medical complications with pregnancy are also more. So the rates of cesarean are also increasing, although there are various efforts being taken to make it within a targeted limit. But when we do say cesarean, no matter what happens, the patient is not very comfortable straight away, because even the patient knows that there are various risks associated with the cesarean section. So because of this, any patient, when we say there's a need for cesarean, they become very anxious. And so, as ma'am has already rightly ma'am, can you I'm not able to change the slide.
Ma'am, I'm sharing on behalf of you, ma'am.
Okay, ma'am, can you change it to the next slide, ma'am? Yeah. So as ma'am had already elaborated, there are various complications associated with cesarean, but when done properly, this cesarean can be a safe surgery. So the various intraoperative complications we encounter are, we all know that cesarean has a comparatively more blood loss than a normal vaginal delivery. So this blood loss need not mean immediately a postpartum hemorrhage, but the normal routine loss in itself is more than a vaginal delivery. And when cesarean is done in a second stage, or if it's in a previous cesarean section, there is also the risk of injury to the visceral organs like bladder and bowel. And also during cesarean or in the immediate postpartum period, there's an increased risk of amniotic fluid embolism. And while making the incision in a patient who's well in labor, when the lower segment is well thinned out, there is a risk of injury to the baby. There can be the scalpel nick on the baby, or there can be difficulty in delivering the head if it's a second stage cesarean. And sometimes there can, if it's in a transverse lie, which is an indicated cesarean section, there can be difficulty in delivering the baby, which in turn can lead to birth injuries. Along with this, there is also the risk of anesthetic complication. As we all know, pregnancy, the patient is going to be in edematous state. There is going to be laryngeal edema. There could be difficulty in intubation. Sometimes when you take the emergency LSCS, there is a risk of aspiration. And there is also risk to the allergic reaction to the drugs used. Next slide, ma'am. So there are very serious cesarean section complications even post-operatively. Next slide, ma'am. Okay. So once the cesarean is done, so this complications which are elaborated were for the intraop. So if we feel like we have crossed the intraoperative period, we have done a neat cesarean section, the problem doesn't end there. The patient is going to be having complications even after the cesarean and needs to be under close monitoring. So the most common immediate complications we can encounter are hemorrhage, which could be either a primary postpartum hemorrhage within the 48 hours or secondary postpartum hemorrhage after 48 hours. In the primary postpartum hemorrhage, the common cause is atonicity, whereas in secondary postpartum hemorrhage, it could either be retained products or infection. So if we are encountering a primary postpartum hemorrhage, all uterotonic measures like oxytocin, carbetocin, prostaglandin, methogen should be used to control the hemorrhage. And if needed, the patient has to be proceeded. If it's intra-op, we can proceed with surgical management. If it's post-op, not settling with the medical management, we need to go for a laparotomy. Whereas if it's a secondary hemorrhage, the primary concern is controlling the infection with antibiotics, ruling out retained products, and then proceeding with the same management, like stabilizing the patient. The next complication we encounter is the previous slide, ma'am. It could be nausea. Most women in the postpartum period, they have nausea. It can happen up to 48 hours. The most common cause is a preloading before the cesarean. So when it's a planned cesarean section, we can avoid fluid overloading, allow the patient to have adequate water intake, avoid prolonged starvation, and also allow early oral intake to avoid this complication. The next complication is spinal headache and back pain. Although spinal anesthesia is being given for various surgeries, we encounter this complaint of back pain more common after cesarean. It could be because of the dilatation effect caused by the progesterone, along with the spinal complaints, and the patient has been having a lumbar lordosis throughout her antenatal period. So that could be a cause which can be managed with analgesics. And in case of spinal headache, advising the patient to have adequate caffeinated intake, adequate oral fluids as well as IV fluids, analgesics, and if needed, a blood patch, epidural patch can also be done. Another complication we have is the infection. The infection can be at various levels. One, it could be at the scar level having exuding pus, or it could be a full-blown infection presenting with sepsis and fever, or there could be infection inside the uterus presenting as endometritis. So the common complaint first would be the fever, tachycardia, and complaints of pain. So we need to find out the cause of infection, cover the patient with a broad spectrum antibiotic, and treat her accordingly. And the next complaint is a lochia. So the lochia discharge can be present till 4 to 6 weeks postpartum, but the patient needs to know that if the lochia is in excess, like she's staining more than 3 to 4 pads in a day, or she is like having passing clots, it is not normal, and she has to be attended immediately. Next slide, ma'am. The other complications the patient can encounter is a breathing difficulty. Sometimes there can be a fluid overload or can be a pulmonary edema following preeclampsia. So the patient can present with breathing difficulty. Sometimes it could also be a pulmonary embolism. So the cause of the complaint should be evaluated and treated. As I said earlier, fever, endometritis complications are presenting with infection. And as ma'am had elaborated, there are various complications related to the wound. There could be wound infection. There could be wound dehiscence. So both of this can be prevented by advising the patient on proper wound care. So we cover the patient with a dressing, a sterile dressing for up to 3 days. And after which, once the dressing is removed, the patient should be advised to keep the wound clean. She can have a regular bath, but she should maintain the hygiene of the wound, avoid contamination with the lochia. And she has to be advised for a follow-up 2 weeks after to ensure the proper healing. There are other complications like venous thromboembolism and paralytic ileus. So paralytic ileus is not a very common complication, but can be encountered. The reasons could be because of the anesthesia or the effect of the estrogen decreasing the parasympathetic activity. So because of this, the patient is going to have difficulty in passing flatus. There will be absent bowel sounds, and she will not be able to tolerate oral intake. There will be absent bowel sounds on examination, and the abdomen would be distended with hyperresonance. So in such a case, the patient should be advised for initially conservative management. We should avoid oral fluid intake. We should put her on Niloral, give a nasogastric suction, and also give the patient, correct the electrolyte imbalance, and prevent opioid analgesics, which can aggravate the condition. So once this conservative management is tried with the nutritional support, and still if the patient is not recovering, we can allow colonic decompression. And if the distension of the colon is becoming beyond 15 mm, there can be a risk of perforation. So in case of perforation or a case not responding to the medical management, a surgical management might be needed. Next slide, ma'am. So these are the various complications we do encounter after a cesarean. It could be infection. The infection could be at the scar, and the other complications are urinary tract infection. During cesarean, invariably we all use catheters. Even if we do remove the catheters earlier, there is a risk of urinary tract infection because of the introduction of foreign body. This can be prevented by using a sterile technique for inserting the catheter and maintaining the catheter hygiene and removing it earlier, like 12 to 18 hours after the procedure. The other infection we encounter, mastitis. Sometimes we have the patient complaining of pain and they do not breastfeed the baby adequately. So we need to educate them that they can have a proper regular breastfeeding technique, because if they do not breastfeed and then it leads to milk engorgement, they can have breast abscess, mastitis, and other complications. There can be a respiratory tract infection and other complications like paralytic ileus, postpartum hemorrhage. Next slide, ma'am. So as these complications are the common intra and immediate postpartum complications, and this makes the patient anxious. So what can we do to make sure that the mother is feeling comfortable? We cannot just tell her, please don't be scared. We need to have a proper protocol for her post-operative care. Next slide, ma'am. So when it comes to post-op care, it needs to be categorized into enhanced recovery after surgery, thromboprophylaxis, PPH prophylaxis, maternal monitoring, pain management, catheterization, ambulation, and with regards to oral intake. So when we cover the post-operative care in all these sections, we can identify the complications at an early stage, correct it, and ensure that there is no maternal morbidity or mortality. Next slide, ma'am. So in the immediate post-operative period, the patient should be in close monitoring in a high dependency unit. In the initial 2 hours, her pulse rate, blood pressure, saturation, and urine output should be monitored every 15 minutes. Because if there is a postpartum hemorrhage or there is some bleeding internally, the first sign is going to be a tachycardia. And if we can pick it up at that point, the amount of blood loss, DIC, and other complications that can result from it can be minimized. And then the patient is going to be nil oral. To ensure that she does not go into dehydration, we need to give her IV fluids, which should be electrolyte-rich, either a ringalactate and sugar-rich like dextrose solution. These fluids should be maintained at 75 to 100 ml per hour. And we can advise her at least 2,005 units of fluid over a 24-hour period if needed. The next thing we have is the antibiotics. Routine post-operative antibiotics are not needed. If it's a planned cesarean without risk of infection, a prophylactic antibiotic 30 to 60 minutes prior to the skin incision is sufficient. If there is a risk of infection, like the mother is having high diabetes, highly anemic, or the surgery was prolonged beyond 2 hours, or there was complication intraoperatively, in that case, post-operative antibiotics with a broad-spectrum cephalosporin can be given. Next, when we come to the analgesics, we can advise the mother to have a multimodal analgesia. She can be given IV paracetamol 1 gram, 6th hourly, or if it's not settling with that, she can take a ketorolac or ibuprofen. It's preferable to avoid opioid analgesics because, as I said earlier, they can cause risk of paralytic ileus. The analgesics can also be given as a suppository form, which can be administered right before shifting the patient from the operative table, which has a better analgesic effect. Next slide, ma'am. So, as I said earlier, in the initial 2 hours, the patient is going to be with intensive monitoring. The factors that we are going to monitor are her pulse rate, respiratory rate, saturation, temperature, and blood pressure. So we can use the early warning scoring system. So if the patient is going to have 2 yellow score or 1 red score, it means that she is having complication and she needs to be intervened accordingly. So if the heart rate is maintaining below 100 and she's having a BP below 140, 90 or above 160, it means the patient is doing well and this needs to be monitored every 15 minutes. Next slide, ma'am. As I said earlier, for the post-op recovery, we are now following the enhanced recovery after surgery. Earlier, we used to have a prolonged starvation for the patient. We would keep her catheterized, advise her not to move for the risk of spinal headache. All of this led to various complications. So now, to allow the patient to have a better recovery and to have early ambulation, we are following the enhanced recovery. Next slide, ma'am. So for this enhanced recovery, we have the pre-op, intra-op, and post-op care. Pre-op, the patient needs to be educated. She needs to know what is to be expected so that she's not afraid. And they should be avoiding the prolonged starvation. We can allow her to have a food 6 hours prior to the surgery and clear liquids till 2 hours prior to the surgery. And during the surgery, we can avoid opioid analgesics, avoid prolonged hypotension, and maintain normothermia. And in post-operative period, we advise them for an early oral intake. Studies have found that the patient can be allowed to have gum chewing, which increases the bowel motility. And they can be asked to start their oral intake liquids by after like 4 to 6 hours. And once they start moving the bowel, once they start passing flatus, they can be allowed to have a soft diet. Next comes the early ambulation. So to ensure the early ambulation, the patient can be asked to turn side to side on the bed from after like 18 hours And after 24 hours after the surgery, the patient can be allowed to walk about. And we should be allowing her for resting periods. She need not have a prolonged bed rest. She can walk about for 5-10 minutes and take a rest. And we can advise her for early catheter removal. As such, we can advise the women to remove the catheter at about 18 hours after the procedure. This allows the women to be ambulant as well as avoiding the risk of urinary tract infection. And we need to have the venous thromboembolism prophylaxis with analgesia and allow the women to have breastfeeding. Caesarean is not a reason to ask the women to delay breastfeeding. She can have an immediate breastfeeding and continue breastfeeding every 2 hourly, even if she is undergoing a Caesarean section. Next slide, ma'am. So when it comes to venous thromboembolism prophylaxis, we need to analyze the risk factors antenatally as well as postnatally. If the mother is having various risk factors like elderly, if there was a preeclampsia, or if it was a Caesarean section in labor, or if there was any high risk like APLA, or she had a venous thromboembolism prior, thromboprophylaxis should be given. So if she falls under the intermediate risk, she should be given 10 days of heparin. Whereas if she's falling under the high risk category, that is, she had a previous venous thromboembolism episode, she needs to be given heparin prophylaxis for at least 6 weeks. This, along with early ambulation, and if needed, the kept stocking, pneumocompression stockings, can prevent the risk of thromboembolism. Next slide, ma'am. So in the post-operative period, we have monitored the mother, we have ensured enhanced recovery, and we have also given her thromboprophylaxis. For pain management, once we switch her to oral diet, we can switch all her medicines to oral instead of the intravenous access, remove the IV cannula, and advise her to be ambulant with good fluid intake. But when the woman is going to be discharged, she can be discharged from the hospital 3 to 5 days after the procedure. She needs to be given advice on all aspects. That is, she needs to be told that she can breastfeed every 2 hourly. She can continue breastfeeding normally. And when she is breastfeeding, she can have a support to avoid back pain and other pain factors. With regards to the diet, the women can start having a soft diet once she's passing flatus. And once she's past 2, she can be encouraged to have a normal diet. Providing abdominal support. The abdominal binders or belts can be advised for the women 1 week after the surgery. This prevents them from having pain due to the sagging of the abdomen, pain on the scar, and they should be told the binder should not be used while taking food or while sleeping. With regards to exercise, they can start walking right after the procedure, but not walking as an exercise, walking for their regular activity. But when it comes to routine exercise, the women can be starting exercise 4 weeks after the procedure. Lifting weights, she can lift only her baby. Lifting weights can be done after 4 weeks. Wound care, as I said earlier, from after removing of the dressing, the women should keep it clean, have daily bathing, make sure it's not wet, not stained with lochia, and ensure that the wound is verified by the obstetrician 10 days after the procedure or 2 weeks after the procedure to prevent any induration or any late dehiscence. Sexual activity. Although it's a Caesarean section and there is no wound on the episiotomy, women should be told that they should defer Caesarean sexual activity for 4 to 6 weeks and should be given adequate contraception. Next slide, ma'am. So they can sit up 12 to 24 hours, breastfeed within 30 minutes, have a light meal within 6 to 8 hours, and walk about from 18 to 24 hours. They are discharged on the 5th day, and they can stop their painkillers in a week, sexual activity after 6 weeks, and exercise after 6 weeks. As for driving, women should be asked to avoid driving for the initial 4 weeks. Next slide, ma'am. Next slide. Change, ma'am. So once the post-operative care is completed, the woman is discharged. We have given her advice. The complications do not stop there. Caesarean can cause long-term complications like abnormal placentation. There is 1 in 200 incidence of placenta previa and 1 in 300 to 2000 for placenta accreta. And the risks are more with previous 3 LSCAs. So identifying the abnormal placentation in future pregnancies is important. There's a risk of uterine rupture if there was a wound infection during her postpartum period, which weakens a scar. There are various scar complications like keloid on the skin, possibility of incisional hernia, scar endometriosis, which is seen very commonly now, which needs excision. There can be formation of isthmosine in about 1% of individual. Studies have found that ismosis, your scar niche is present in about 70% individual after cesarean, of which 30% are symptomatic. The most common cause for ismosis is found to be defect in the scar, where the myometrium is not completely intact. Additions. Next slide, ma'am. There have been various scoring for additions after cesarean, and studies have found 24 to 73% of additions after primary cesarean section. So techniques like preventing tissue ischemia, preventing trauma, preventing prolonged surgery, minimizing the use of foreign material, cautery, and using non-reactive sutures can minimize the risk of additions. The use of hydroflotation and other addition prevention measures are not very successful and not evidence-proved. These other additions are complication when the patient is going to go in for a repeat section. At that point, if the uterus is densely plastered, there's a risk of bladder and bowel injury, difficulty in accessing the lower segment and delivering the baby. So if the primary cesarean is done very carefully to reduce the incidence of additions, the complications in the repeat sections are minimized. Next slide, ma'am. And once the additions are present, the patient is going to complain of chronic pelvic pain, and the anatomy of the tubo-ovarian anatomy is going to be distorted, which can result in subfertility. And the cesarean scar can cause pain leading to preterm birth in the next pregnancy. And when it comes to mode of delivery, VBAC has a success of 70% and with a risk of 0.5% rupture. And a baby delivered by cesarean is tend to have altered gut microbiome, leading to reduced immunity for the baby and gut complications in the immediate neonatal period. So a properly done cesarean with good care in the postoperative period and a caution for a long-term complication. Next slide, ma'am. Can make sure that the woman is hale and healthy without morbidity, and she can indeed be happy about having the cesarean scar rather than be scared of it. Thank you.
Thank you so much, ma'am. I will request our chairpersons to kindly summarize the talk. Do we have Dr. Divakar with us here? Dr. Vijay Kumar? Dr. Doris? Dr. Doris is here. If anyone has any questions, we can take them. If we have any of our chairpersons, Dr. Doris, Dr. Divakar, or Dr. Vijay Kumar, we would like to hear a few words from them. Ma'am, Dr. Sadhana, ma'am, you are on mute.
So actually, we thought that we can invite from any comment from even Vidya, Dr. Sunanda, Dr. anyone for the comment. We have the chairperson. We don't have a chairperson, Apurva.
I can see Dr. Doris here, but let me call her.
I think Dr. Niranjana.
Radha, you will.
Yeah, her presentation was excellent. And then what I feel is whatever the complications anticipated or whenever we see these complications, we are very much, we should mention those complications, whatever has occurred. The documentation is very important. Of course, we are afraid of medical legal implications, and many times we don't document them, and we also dig our own grave if they are not documented. That is what one comment. And I think her whole presentation was a complete presentation, and she covered almost all complications of cesarean section.
Dr. Divakar
for like acceptance for a very, very short notice. So Apurva, you can go ahead with the next session.
Dr. Divakar has joined. Can we have his comments?
Yes, Dr. Divakar, please. Unmute Devakar. Dr. Devakar, unmute.
It was very nice presentation, madam. Actually, it was in detail. Everything was covered in the topic, ma'am. It was very nice. Thank you, ma'am.
Thank you so much.
Yeah, yeah.
Thank you, sir. Ma'am, can we proceed with our next session? So our next session is on indications and audit of Caesarean section with a special reference to Robson's classification. The speaker we have today with us is Dr. Vidya Thobi, and to chair the session with us, we have Dr. K. Purushottam, who is presently the Associate Professor at RVM Medical College. He is the Joint Secretary of TCOG and a UG and PG examiner, and presently a consultant at Warangal Hospitals. We welcome you, sir. We have Dr. Lakshmi with us, who is the Assistant Professor at Kakatia Medical College, Warangal. Welcome, ma'am. And Dr. Vijay Lakshmi, who is the President of Mehboob Nagar Society. I will request Dr. Purushottam to kindly introduce our speaker for today, Dr. Vidya Thobi. Sir, kindly introduce our speaker. Unmute, sir. I think sir has lost his connection. If Dr. Lakshmi or Dr. Vijay Lakshmi can please introduce our speaker.
Yeah, I'm Dr. Vijalakshmi.
Yes, ma'am, please.
Introduction.
Kindly introduce Dr. Vidya Thobi.
Okay, ma'am. I'm very pleased to invite our speaker, Dr. Vidya Thobi. She's President, case OGA 2324, Professor and Head of Department of Obstetrics and Gynecology, Alamein Medical College, Vijaypur. She's Chairperson of Food, Drug and Medical Surgical Equipment Committee, ICOG Governing Council member. She's Foxy Champion Award she got in 2019. She is National Corresponding Editor of Jogi, Organizing Chairperson of Case OGA, President Bijapur OB-GYN Society, Secretary Bijapur OB-GYN Society 2007, and she has publications in various books and contribution to Foxy. She has various papers in national and international conferences. She organized various CMCs, workshops, and awareness programs. I welcome you, madam.
Thank you, Dr. Vijay Lakshmi, and thank you, Dr. Sadhna and the team for inviting me here for the very important talk. I see Dr. Revati Jankiram also here. Thank you, madam, for joining. And so many societies have joined Warangal, Mehboob Nagar, Vizag, Virudnagar, Tuticorin, Davangere, Khammam, Tanjavur OBGYN Society. So welcome all the society and delegates, and this is very important topic we are going to discuss, that is indication and the audit of cesarean section. I request Apurva to change the slides. Can you do it for me, Apurva? And my battery is dying, so maybe I'm traveling also. I'm talking from my car.
Sahiti from
kindly
Shield is
please-
sharing the slides, ma'am. I will
Sahiti,
do.
Sahiti, please go on changing. No problem.
Okay,
no
ma'am.
problem.
Okay, sure.
And if I stop in between, the Apurva will continue with my slides. Whatever.
Okay, ma'am.
Thank you very much. Thank you.
Ma'am, you are on mute.
Yes. I just apologize for that. I will not go into the indications of cesarean, the definition of indication of cesarean section. Next slide, please. I want to tell something, that all the indications are applicable both in developed and developing countries settings, and these can be classified into absolute and relative indications. Sahiti, please go on changing the slides now. Next slide, please. I have finished the definition of the and classification. Yes. So the absolute indications mandatory needs the cesarean delivery. So therefore, it will also always contribute to the baseline cesarean rate and uncommon. And the relative indication represent the potentially modifiable conditions that may or may not be always lead to the cesarean section. So such relative indications can be subdivided into maternal, obstetrics, and fetal categories. So these are the absolute, like prior to classical cesarean, complete placenta previa, cord prolapse, and others. And relative indications are maternal. The most common is a maternal request, various infections, medical comorbidities, aortic stenosis, and other things, and prior myomectomy, prior third or fourth degree perineal lacerations, and then obstetrics one, rest of labor, previous section, multifetal gestation malpresentations, then placenta previa, cephalopelvic disproportion, malformation, macrosomia, and non-assuring antepartum CTG tracings, non-assuring intrapartum CTG tracings. So classification, which is based on urgency, that is the RCOG classification. Next slide, please. The classification goes on as a category into 4 categories, and it is modified of classification, which was earlier proposed by Lucas et al. The color scale reinforces the need to recognize that the continuum of urgency applies to the cesarean section rather than discrete categories. So if you see next slide, please. So if you see the categories like urgency, the maternal and fetal compromise, and second one is no maternal and fetal compromise. It definition goes that whenever there is an immediate threat to the life of woman and fetus, that is category 1. No immediate threat to life of woman or fetus, that is category 2, requires early delivery, that is category 3. And whenever there is a time to suit the woman and maternity services, that is category 4. There is no maternal and fetal compromise in these categories. So next slide, please. So this is a classification of urgency, immediate, within 10 to 30 minutes, threat to life of a woman of a baby or baby. If there is a prolonged bradycardia, cord prolapse, uterine rupture, or if you do the fetal scalp blood pH less than 7.2. Next slide. So in category 2, that is in maternal and fetal compromise, not immediately, which is not life-threatening, antepartum hemorrhages, or whenever there is a non-progress of labor. Category 3 is no maternal or fetal compromise, but early delivery is required, which includes non-progress of labor, booked for elective cases with early rupture of membranes, and this should be preferably within 75 minutes. So emergency is immediate threat to the life of a woman or fetus. Decision delivery interval here is very important, within 30 minutes. Urgent is maternal and fetal compromise, which is not immediately life-threatening, and scheduled is which needs early delivery but no maternal and fetal compromise. Elective is at the time to suit the woman and maternity team. Now, factors for the rising of cesarean section rates. So rising incidence of primary C-section is because of rising fetuses before term. So primary cesareans are increasing, so repeat cesareans are increasing, and the risky fetuses are also increasing before term, like fetal growth restriction, high-risk pregnancies. Detection of high-risk pregnancies are also at increase. Failure of induction of labor is very, very common. Decline in the operative vaginal deliveries. None of our postgraduates are trained in these operative vaginal deliveries. Decline in the breech deliveries, and elderly women and associated medical complications are on the rise, and wider use of electronic fetal monitoring and the diagnosis of fetal distress. And most important is the fear of litigation in the obstetric practice and the maternal request. These two indications are also on the rise. So more frequent use of C-section for previous section. Previous section, nobody does VBAC nowadays, and cesarean for almost all breech deliveries. Detection of high-risk women, as I told, and the increased rates of obesity again. So trends of cesarean section in healthcare providers, spouses, and obstetricians. This was a study done, and they're concerned with the perineal damage, injury to the baby, and electively timed delivery. So too posh to push. And in 1996, this study was published where the incidence almost touched to 68 to 70%. So we know about next slide, please, Maneka Gandhi, who next slide, please. Yes, doctors who carry out cesarean operations without a valid medical reason must be named and shamed, said the union. So that time it was a very hue and cry that what happened. Really, we are very justifiable cesarean sections. The growing number of cesarean section leads to higher number of repeat section as I told. And earlier we used to tell once hospital delivery, but nowadays it is Sahiti. So recently, the WHO data on frequency of cesarean section shows that the cesarean section has increased dramatically throughout the world in the past 2 decades. And this is very, very independent in the stage of development of the country. So there is at least 2 significant reasons for this increase, as we were discussing. No, the primary cesarean section and rapidly decreasing rate of vaginal birth after cesarean section. So Saiti, jump on to the next 2 slides. And now we come for the audit of cesarean section. So when we talk of audit of cesarean section, which plays an important role in
Vidya ma'am, we are not able to hear your voice.
Ma'am, please unmute.
Yeah. Now I am audible.
Yes,
Hello?
ma'am. Yes, ma'am. Now you are audible.
Yes, because it is very difficult to join while traveling. So sorry about that. Okay. Yes. So I was talking about the various review articles which are published, and these review articles and various audits done in various countries. They have shown that the maternal request is the 5th most common reason which was given in performing cesarean after fetal compromise and failure of progress, repeat cesarean and breech presentation. So first was this one repeat cesarean, then came failure of progress was and the previous cesarean were the most common indications. Now, what is the Indian scenario? Indian scenario is a National Family Health Survey. Combined cesarean section rate was around in Telangana they found that is 34.1, and many hospitals say it reaches up to 70 to 80%. Now, how to reduce? Hello.
Yes, ma'am, you are audible.
Audible. I'm not able to see you people. Okay. Am I audible now? Yes. So, these are the reviews which were published. I published by various authors, and I will not go into the details. But there, what they said was about the various indications and what were the common scenario. Next slide, please. Yes, I talked about this cesarean delivery and what was the common indications in various hospitals in UK. I was talking about the Indian scenario, and in Indian scenario, I told about the various indications. Now, how to reduce the higher cesarean rates? The more liberal use of external cephalic version in breech, assisted breech deliveries, maintenance of partograph, active management, and use of Robson classification and trial for vaginal birth after cesarean should be encouraged. For nearly 30 years, the international healthcare community has considered the ideal rate of cesarean section. So which is the ideal rate for the cesarean section is around 10 to 15%. And this was based on the following statement by the panel of reproductive health experts at the meeting organized by WHO. So there is no justification, they say, for any reason to have the rate higher than the 10 to 15%. Then this is next slide, please. So there is a very good article published in our own the Jogi. If you go through this article, this is very good article. That is a rising cesarean rates are the primary sections overused. So what they found out was there was a doubling of cesarean section rate from 2000 to 2015 globally. This was an eye opener for everyone, and it was discussed in the FIGO World Congress as well. And this rapid increase in the rates without clear evidence of concomitant decrease in the maternal or neonatal morbidity or mortality raises significant concern that cesarean delivery is overused. So to save any mother or baby, we are just overusing cesarean deliveries. And this review addresses the issues which are related to the exponentially rising rates. And for that, the strategy is to reduce, how to reduce this primary cesarean section. This previous cesarean has a main contribution, no? So how to reduce the primary cesarean is our focus. And for that, we have to optimize the indication of primary cesarean section and rethink for the modifiable indications like labor dystocia, indeterminate fetal heart rate tracing, and all those things. So one has to rethink about what are the modifiable cesarean sections. So you have to find out what is the universal classification system. And we all know that this 10 group classification, which is commonly known, which has been introduced by Robson. And in 2014, conducted a systematic review on the extent to assess the pros and cons of its adoption, implementation, and interpretation, and to identify the barriers, facilitators, potential adaptations, and modifications. Yes. So next slide, please. This is an option he introduced in 2001, and all
Yes. So,
he has classified in one or the other categories.
am I audible?
Next slide, please. You
Yes.
know about this
So,
because most of us.
hello?
Next slide, please. So we know about this Robson classification.
Vidya ma'am, you are not audible.
Hello?
Vidya ma'am?
Hello?
Yes, ma'am.
Hello?
Yes, ma'am. Yes, ma'am.
Now we can hear you, ma'am.
So I joined from my mobile because it was not from my laptop. I could not join. So I am talking from my mobile. So I will please move on the slide. I was talking about the Robson classification, and these are the 10 groups where first two are nulliparous. One is spontaneous. Second one is induced. Third one is multiparous without previous scar and spontaneous labor. Fourth one is multiparous without previous cesarean scar, induced or cesarean section before labor. 5 is previous cesarean. Most of our indication happen to be in the group 5. And 6 is all nulliparous breach. 7th is multiparous breach and previous cesarean. All multiple pregnancies, including cesarean, are included in 8. All abnormal lie grows directly to 9, and 10 is all single cephalic less than 36 weeks preterm, including previous cesarean. So some of the indications are out of these, they are unclassified. Next slide, please. So these are the definitions of various core variables one should know. These are the obstetrical variables we take into account. One is parity, previous cesarean, onset of labor, number of fetuses, then gestational age, fetal lie, and presentation. And other is the definition of core variables. We do other variables are parity, then previous cesarean section. So these are the other variables. Okay, next slide. In the next slide, it is. So these are the variables which we take into account whenever we are defining and putting them in this Robson classification. Then other one is onset of labor, and either it is a spontaneous or induced or pre-labor cesarean section, and number of fetuses like singleton and multiple pregnancies. So these are the various variables which are taking into account even the gestational age, term, preterm, fetal line presentation. Either it can be cephalic, breech. Next slide. Next slide. So cephalic, breech, transverse, or oblique lie. So these are the other obstetric variables which are taken into consideration. And next slide, please. So they have also considered about the subdivisions of the 10 groups. These are the, many of them they use subgroups because certain groups like in group 2, 4, and 5, they may prove to be more meaningful than others, but this can vary from the site to site. The objective of this subdivision is to further increase the uniformity and homogeneity of the groups by stratifying the women within that group according to certain relevant characteristics. And this can be especially useful when planning the implementation of clinical interventions in specific subgroup. The importance and potential usefulness of these subdivisions will depend on the size of the group within the specific setting where the classification will be used. So it is very important to remember this. Any analysis of this subdivision by itself or by misleading, no attention is given to what has been left out. So these are very important things one has to take, and one has to do repeated revisions. And even in Manyata, we do this subdivision class, means Manyata last our 16 is Robson's, and we teach even the staff that how to classify, how to audit, and how to give a specific importance why we are classifying this and how we can that we can modify. So these are the common subdivisions, and the how they are subdivided: 2A and 4A, 2B or 4B. So these one has to take in account the rate of cesarean in 2 and 2B are induced nulliparous and multiparous women especially can also be used. So these one has to, and ultimately what we feel is how to use the flow chart. It seems to be complicated, but it is very easy to use. Whether you can just put it in the multiple pregnancy here. If it is yes, directly it will go to subgroup 8. Then comes the transverse or oblique lie, whether it is a breech, whether it is a gestational age, you have to take into account. You can just follow the flow chart, and you can just come into conclusion in which group you can put them. The another slide, next slide, this you can paste it, and this is from the supporting group by Dr. Nusrat from Fernandez. she has simplified this Robson's 10 group classification for all the birth. So we can even put some calculator. Next slide, please. So you can just use some spreadsheet or automatic calculator. Manually, you can put it the data, and gradually it will go to certain the classification, and you can feed the data, and at the end of your month, you can just classify. So this is very useful for the spreadsheet or automatic calculator. Next slide, please. So this is a WHO statement on the cesarean section rate. That is, every effort should be made to provide cesarean section to a woman in need rather than striving to achieve the specific rate, which is very important. And the effects of cesarean section rates on other outcomes, such as maternal and perinatal morbidity, pediatric outcome, and psychological or social well-being are still unclear. And more research is needed to understand the health effect of cesarean section on immediate and future outcome. There are FIGO recommendations and even our FOXY recommendations. The hospital should be obliged to publish annual cesarean section rate. They should use uniform classification system. They should be properly counseled for the risk and benefit of cesarean section delivery. And this money which is saved out of lowering the cesarean section again should be investigated for the resources. That is what we say. And in rural areas, access to the cesarean section, fetal surveillance, and assisted operative vaginal delivery to be made available. WHO also recommendations are the same. Plus, they say that it is mandatory second opinion for decision, which is very important. FOXY recommends for the setting up of cloud-based registry, which is linked to the website, which will have anonymous data also can be fed, and so that we can have audit and how to reduce the cesarean section rates. So these are the few of the FOXY recommendations. And what WHO expects that this classification will help the healthcare facilities. One is optimize the use of cesarean section by identifying, analyzing, focusing interventions on specific group of particular relevance for each healthcare facility. Second one, assess the effectiveness optimizing the cesarean section. Third one is assess the quality of care, clinical management practices, and outcomes of the group, and assess the quality of the data which is collected. Quality of data is very important while raising the staff awareness about the importance of data and its use. So data collection is also important. Putting it into the right is very important. This is just a checklist for the case of previous section. It is not a Robson's classification. So whenever a previous section case comes, this can be fed, and you can just find out whether you can do the vaginal birth or TOLAC, vaginal birth after cesarean, what is the modifiable, all this. Just I put this checklist. And thank you for the patient hearing. Thank you, Dr. Sadhna Gupta and team. I wish her all the best for her election. So thank you very much. I am also going in for a governing council election. So please vote for me as a governing council member. So thank you very much.
Thank you so much, ma'am. Thank you for taking all the pain and talking to us and delivering such a fine lecture while still traveling. I will request our chairpersons to kindly sum up the talk. Yes, Dr. Vijayalakshmi, ma'am, please.
That was a very elaborate talk, madam. And it was done very well, very clear. Very nice talk. She's covered all the things, and especially importance of Robson's criteria and how it's going to help in future this thing of pregnancy for government and for organizations, how to plan. That was very nice one. And I thank Sadhna madam and the team for giving me this opportunity, and all the best, madam, for your elections.
Purushottam sir, please your expert comments on the talk. Sir, you are on mute. Please unmute.
Very detailed lecture.
The mic is off. Your mic is off, sir.
It is a heavy rainy clouds are there. Okay, madam. Can you hear?
I think sir is having some network issue.
Probably is not being able to join. So by the permission of Dr. Sadhna ma'am, can we proceed? Can we proceed towards can we close the scientific session and proceed towards a panel discussion? For the panel discussion on surprises and difficult situations in C-section, I hand over the stage and the mic to my fellow moderator, Dr. Ayushi Agrawal.
So thank you, ma'am. And we begin with the fourth and the last session of today's webinar, which is a panel discussion on surprises and difficult situations in Caesarean section. For panel moderation, I invite Dr. R. Padmaja ma'am. Ma'am is Professor of Obs and Gynae at Rangaria Medical College, Kakinada. Ma'am is MBA trained in laparoscopy and ultrasound faculty in national conferences in Yuva Foxy. Ma'am is a passionate teacher and a traveler. A very warm welcome, ma'am. Next, I would like to invite our panelists for the panel discussion. We have with us Dr. B. Sandhya Rani ma'am. Ma'am is head of department for DNB Institute at Lakshmi Narishima Hospital and a chief consultant over there. Ma'am is director at Ekashila Hospital, past general secretary of Warangal Obs Gynae Society. Ma'am has participated as a speaker in various national and international conferences and organized many CMEs and conferences at Warangal. Very welcome, ma'am. Dr. Manasa Shyamala ma'am. Ma'am is joint secretary at Warangal Obs Gynae Society. Ma'am has a fellowship in ART. Ma'am has worked under NRHM SCS for 5 years, and presently ma'am is a clinical head consultant at Med Health Hospital, Warangal. Warm welcome, madam. Dr. Uma Maheshwari ma'am. Ma'am has very HIV department in charge at Rajapalayam GH for past 8 years. Ma'am has raised HIV awareness programs for past 12 years. Ma'am has conducted many HIV positive deliveries and many health camps in municipality. Ma'am is president at Virudhunagar Obs Gynae Society. A very warm welcome, ma'am. Dr. Mary Genova ma'am. Ma'am has done her UG and PG from Madurai Medical College and passed with gold medals. Ma'am is founder president of Virudhunagar West RSS OG Society and member of MOGS since past 30 years. Ma'am is director of Joseph Specialty Hospital, Sri Villiputur. Very warm welcome, ma'am. Dr. Bhubuthe Arul Prakash ma'am. Ma'am is president Foxy at Toothkudi Obs Gynae Society and retired from Toothkudi Medical College. Ma'am has special interest in Tamil. Ma'am is Collector's Award for FP Achievement and Best Doctor Award from IMA. Ma'am has conducted community awareness programs in school, colleges and villages. A very warm welcome, ma'am. Dr. Jasmine Rajesh Tilak ma'am. Ma'am is undergraduate from Tiruvani Medical College and postgraduate from Madurai Medical College. Ma'am has received infertility training from CIMAR and ma'am is practicing in Rajesh Tilak Hospital in Fertility Center for the past 11 years. Ma'am is present secretary of Toothkudi Foxy Society. A very warm welcome, ma'am. Dr. Medanama Mithla Vijayashri ma'am. Ma'am is professor and head of department at Mamta Medical College, Telangana State. Ma'am is graduated from KMC Mangalore University and postgraduate from Mahi University, Manipal. Ma'am has been the former secretary for 3 consecutive years from 2008 to 2012 and 2016 to 2017, organizing secretary 2nd TCOG 2016, and at present President KHMOGS. Ma'am has conducted many CMEs and workshops and awarded FICOG 2017 January at AICOG conference Ahmedabad. Ma'am has a list of awards and conferences organized by the madam, and ma'am had 35 publications in international and national journals. A very warm welcome, madam. Dr. Sunanda Rani Gupta ma'am. Ma'am is Director and Chief Consultant Gynecologist at Nikita Hospital, Visakhapatnam, a Center for Advanced Gynae Endoscopy. Ma'am has been the Joint Secretary OGS at Visakhapatnam, and ma'am has a special interest in laparoscopy and conducted many endoscopy workshops. Ma'am has presented papers at state and national levels. Warm welcome, ma'am. Dr. N.B. Shivani, ma'am. Ma'am is consultant obstetrician and gynecologist at Sri Krishna Health Center, Visakhapatnam. Joint Secretary Obs and Gynae from 2022 to 23, and ma'am has a fellow in gynec endoscopy from Germany. A very warm welcome, ma'am. Dr. T.M. Swati, ma'am. Ma'am has worked as assistant professor at Thanjavur Medical College for 5 years and presently working as consultant at NM Hospital Private Limited, Thanjavur. A very warm welcome, ma'am. Dr. Ashmita, ma'am, is from Thanjavur Obs Gynae Society. Very warm welcome, ma'am. Now I hand over to our moderator for the panel discussion. Welcome, ma'am.
Thank you. After so much of discussion, it's nice to have the whole of the panel present here. Niharika, may I have the slides, please?
Yes, ma'am. I've just started.
Padmaja ma'am, please log in from one device. We are getting echo. Please log in from one device only, ma'am. Log out
From one device. Okay, okay, fine. Okay, am I audible now?
Yes, ma'am. Thank you, ma'am.
Right, so before starting this, before we go on to difficulties and surprises in cesarean section, and these slides are prepared by, are given by Dr. Sadhana madam. So I would just like to know, I would like to ask Sunanda, what preparations would you like to have for a hospital? And this, of course, the next slide, please. This is already shown by Dr. Sadhana. Next. This also I'm skipping. Next. This, most of us know this. Next. Next. Yes. So what is the basic minimum need for C-section operation theatre? Have we left out anything? Do we need to have an operation theatre checklist? Or do we need to have a specifically designed operation theatre taking view of special needs? And are you battlefield equipped? Sunanda?
Yeah, good evening, everybody. It's a pleasure to be part of this panel. Coming back to the question, so about the OT setup. As you know, cesarean section is a very routine surgery, but before planning for the theatre, it's better to categorize them into a high risk and a low risk surgery, low risk cesarean. That always helps us in planning ahead. A low risk cesarean, just like any other cesarean, is we have the routine OT setup. But especially as today we are our topic of discussion is more of a high risk cesarean and difficulties. I would stick on to the setup for the high risk case. So OT setup first, when we have decided it is for a high risk case, first we have to organize our team. That is the most important thing. We have to have an experienced anesthetist assistant and an experienced pediatrician. And coming to the OT equipment, apart from the routine, because we do C-sections in a very basic setup from the PHCs and the CHCs and very basic things. But the high risk cases, we need to have a multi-para monitors, a good suction, diathermy, and if possible, a vessel sealer and a provision for conversion to GA, because most of the setups at the rural centers, they do not have GA setup. So when we are planning a high-risk case, it should be definitely done in a high-risk center. And about coming to the OT instruments, apart from the routine OT instruments, we should have a green armitage forceps, vascular clamps, and a vaginal clamps to occlude the uterine arteries from below. And then again, a ventouse outlet, then a large speculum, sponge holders, and a uterine pack. And we should have a provision for the balloon tamponade, or if it is not available, condom tamponade or PPH cannula. These are the basic things when we are planning for the setup. And the routine OT drugs, like it should include all the PPH drugs, oxytocin, prostaglandins, and all that. And suture materials, we have to be ready with all the suture materials, adequate in number and the right choice and all, before planning for the C-section. And as per the FOXI guidelines, we should go ahead and prepare the emergency obstetric kit, which contains all the routine IV fluids, cannulas, like test tubes for the blood sampling and all. And as I told you, the PPH kit, which contains all the oxytocin. These should be the basic things which should be readily available. And the surgeon should order the team to make all these things ready.
Thank you, Sunanda. And having a checklist definitely goes a long way in preventing any complications in any surgery, more so a C-section. Please keep this slide on only. I'll ask for the next slide. Right. Dr. Swati, are you there, please? Hello? Is Dr. Swati here? Please unmute yourself. So Dr. Swati isn't there. Dr. Jasmine? Is Dr. Jasmine here, please? No? Dr. Shivani?
No.
So what are the common difficulties you would expect to find in a section, Amma?
It's
commonly encountered ones. Yeah.
Hello.
Yes, you're audible.
Yeah, yes, ma'am. It's first, it's very difficult to access to the lower uterine segment, ma'am, and it's complicated. Complicated fetal extraction will be there, and there will be abnormal placentation, and there might be injury to the urinary bladder and surrounding structures.
Okay, are we done?
Hello.
Are we done, Amma?
Yes, ma'am.
Yeah. So most of, and beyond this, of course, this laceration can easily cause what we commonly encounter as life-threatening hemorrhage. Right. Next slide, please. Thank you, Shivani. Now, this is the case situation 1. She's a third gravida, a rural woman. She's had 2 previous sections. 1 live child, 1 vertical incision at a rural PHC. Child expired after 1 hour. Second transmission was Joel Cohen. Child is alive and healthy, 2 years old. Has come to you with mild pain on and off. Scan shows 36 weeks, septic presentation, placenta upper uterine segment like it is normal. Hemoglobin 10 grams per deciliter. Other investigations are within normal limits. On examination, fundal height is 36 weeks, floating head, middle heart is low. She wants you to give her a date for the C-section, as she is coming from a long way and wants C-section in your facility, especially as she has lost her child after the first section. Now for you, is it an easy or a difficult situation? Do you question yourself as to what you have to fulfill? How to optimize the pre-cesarean workup, and patients to know now where the scar will be. So, is Dr. Pungvatai there?
Yes, ma'am.
Yeah, Dr. Pungotai and Dr. Asmita. So this has a battery of questions. So these two questions are for you. If Asmita is there, she isn't there. Hello? Dr. Asmita isn't there. Dr. Ayushi? No, she also isn't there. Right. So Dr. Pungotai and Dr. Manasa Shyamala. Yes. Waiting for responses. Yes, Shyamala madam.
Since she lost one child, ma'am, so maybe we should ask the questions like regarding the neonatal ICU facilities available with the present center where you're planning to do a cesarean section, and the availability of blood, ma'am.
Yes.
Whether it is equipped with blood bank.
Yes.
And like how in the previously how man has mentioned, like the facility whether the spinal or the regional anesthesia, can it be converted to general anesthesia on those facilities? So here my main concern would be like regarding the neonatal ICU.
Yes. Okay. Thank you. Mary Genova, ma'am, your inputs, please. Ma'am.
As we start season, we addition then we expect when doing surgery.
Ma'am, you're not very audible. Or do I have a problem listening, or is everybody encountering the same situation?
Thanks.
Can you listen to ma'am speaking?
Some echoing is coming in the background.
It's very disturbing, ma'am, the background voice.
Yes. Ma'am, continue, ma'am.
Around 38 weeks.
Yes.
There's a lot of disturbance.
Yes. But everybody's voice carried through properly, ma'am.
Yeah, yes.
So please, would you continue, ma'am?
Is anybody taking the question?
Yes. I've asked this question to Dr. Mary Genova. Dr. Manasa Shyamala has already answered. And I'm waiting for Dr. Mary Genova's inputs. Anyway, fine. Dr. Uma Maheswari is there.
Yes, madam, I'm there, madam.
Please, your input also, ma'am.
Am I audible, madam?
Yes, you are, ma'am.
Yes, madam. Good evening to all, madam.
Please be a little louder.
Good evening to all, madam.
Yes,
Am I?
Yes, please.
Yes, madam. Actually, I planned the cesarean section at the time of around.
Yes. Ma'am, please be louder.
I'll plan the cesarean section around completed 38 weeks, madam.
Yes.
And then we go for a low uterus cesarean section only.
Yes.
We are ready for facing the problems like additions, postpartum, and in addition to that, adherent bladder injury, everything should be ready. Blood should be ready for the patient, and it will be a planned surgery, madam.
Yes, it has to be a planned surgery. At the same time, taking care that we do not cause iatrogenic prematurity. Right. Thank you. Next, you have opened it via previous transverse incision. While opening the previous slide also, in addition to the things said, it says that you have to excise the previous scar. Most of us do that, right? And of course, when you plan it close to 38 to 39 weeks, you will have a good and adequately formed lower uterine segment, and your dissection planes will be better, right? If the segment is thin, you encounter less hemorrhage, and if the muscle is thinner, you have a better dissection plane. Next slide, please. Yes. So while opening the parietal peritoneum, you find more space to enter into the abdomen. Uterus is densely adherent to the parietal peritoneum. How do you facilitate entry into the abdomen and access the lower uterine segment? Is Dr. Vijayasri there, please? No? Okay. Dr. Sandhya Rani? No? Who else is there? Dr. Jasmine isn't there. Dr. Pungatai, I have asked something already. Asmita isn't there. Dr. Swati? He also isn't there. Okay, Dr. Mansa, will you please answer your inputs? Sunanda, you want to add?
Hello. Yeah.
Yeah, add.
I think that most of the panelists are not here. I think we better carry about this.
Yeah.
When it is, we have dense adhesions, better to go with a sharp dissection and with the scissors placed close to the uterus. I mean, like close to the abdominal wall. And again, when we do not find a plane at the center, probably it can go for a lateral approach.
So
Be
we
careful.
Go from wherever you get a safe space. Yeah.
Yes, sharp dissection. And then avoid the scarred areas. And if possible, go laterally. And identify the bladder. Especially, we can do this by identifying the median umbilical ligament and the medial umbilical ligament. So once you find that, or else when you have difficulty, actually you can just ask your assistant to push the Foley's from below, and then based on the guide, it gives the Foley's bulb. You can just give an incision above. That is one thing where you do. About the bowels also, you have to be better avoid cautery and take a sharp scissors and release the bowel adhesions. Sometimes, rarely, in case there are severe adhesions, you have to go for an extraperitoneal approach also. But usually that is rare. You should be able to find an approach when you go ahead with these maneuvers. But in case it is possible, then that is one thing you can do.
Right. Thank you, Sunanda. Next slide. Now, I have a request from the persons who are there. Kindly type your name so that I know who is on screen and who is off screen. All I'm getting is doctor, 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 doctor. So I have to refer my list and again come back here and see who's there and who's not there. Mary Genova madam's name is there. All right. So what are the difficult situations? One is a floating head. Yes, somebody is speaking.
Mary Genova.
Yes, ma'am.
Can you hear me, ma'am?
Yes, please. Yes, ma'am. Okay. So in previous surgeries, inflexible scar tissue may need a bigger incision for the easy delivery of the baby, and a floating head is difficult to grasp, control, and give traction to. It cannot be readily pulled or guided through the incision. The uterine forces do not push the head towards the incision, and fundal pressure pushes the head laterally rather than towards incision or change the presentation. I think most of us have encountered this. The head is unmolded, there is no leading cephalic point, and there is a thick lower uterine segment. Next slide, please. So for a floating head, you would like to do a C-section at 39 weeks or at the onset of labor. The skin incision size should be appropriate, and it is always better to excise the previous scar and a modest fundal pressure. Some people use oxytocin, and after rupture of membranes, all of us have been told this. Wait for some time for the amniotic fluid to drain and the head to settle down. And if there is excessive liquor, give a small incision and let the liquor drain, and then you can extend the incision. Next slide. So assisted cesarean delivery, forceps. Would anyone like to talk on this? Madam, Genova madam, please. Yes. Yes, ma'am. Ma'am, your audio is not clear, ma'am. So anyway, we can use one blade as lever. Both blades are used to extract the head through the incision. And during the forceps blade application, flexion of fetal head is maintained as far as possible with little fundal pressure to push the head towards incision. In both blades application, lower blade of forceps is applied first, followed by the anterior blade with the concavity of pelvic curve towards the fetal occiput, and then controlled extension is carried out. Then what are your concerns here? Keep the Wrigley's forceps steady. Shivani, any experience with vacuum delivery of a floating head in a C-section?
No, ma'am.
Yes. Shivani.
Yes, ma'am.
Yeah.
No, ma'am. It's better to go for. It's easy, but we can't say every time it will be that effective with the routine vaginal vacuum delivery, ma'am. Vacuum of.
Okay, Dr. Manasa Shyamla.
No, ma'am. Never used it, ma'am.
Never used. Anyway, but people do use it, and people also use single blade also, no, vectors. Many have. The problem with the vacuum is that they can pop off if they're not properly applied, and you need a negative pressure of about 300 to 400 millimeters of mercury. Otherwise, it is also a good alternative. Next slide, please. So, is vacuum safe? It is a rapid method. Less fundal pressure is required. There is lesser extension of uterine incision, but there are reports of neonatal injuries like cephalhematoma, subgaleal hemorrhage, and especially after use of soft silastic cup in a C-section. And we need further research to clarify safety of vacuum assistance in C-section. Next slide, please. So we can also do an IPV or an internal podalic version. Next slide. So for a floating head, rehearse and practice every technique. Forceps should be available on Caesarean. Previous slide, please. Forceps should be available on a Caesarean trolley and C-section operation theatre. Next slide. We are going ahead with the third C-section with fan and steel incision. While you dissect the bladder, you see the Foley's valve in front of you. How do you deal with the situation? How do you prevent such a situation? Ma'am, Violet Sari, ma'am. You're there on screen. Are you a panelist? Yes. I can't listen to you, ma'am. You're on mute, maybe.
Hello.
Would you like to answer, madam?
Yeah, sure.
Yeah. Answer.
Hello. Yeah. Actually, when you means you have injured.
No, not you, Sunanda.
Okay.
Not you,
That's
not
fine.
you.
Okay, I'm sorry.
Can you please unmute? Yeah, unmute yourself and speak, ma'am.
Violet Sari, ma'am.
Now I am audible, madam.
Yeah, what is your name, ma'am?
I'm Dr. Uma Maheshwari, madam. Good evening, madam.
Dr. Uma Maheshwari. Yeah, good evening, madam. Please.
Yes, madam. It will be actually a very horror situation.
Horror situation, agreed.
So first I'll try to deliver the baby.
Okay, madam, please be a little bit louder.
First I'll try to deliver the baby. Baby delivery will be the first thing for me. As soon as I deliver the baby and hand over to the pediatrician, I'll try to remove the placenta. As soon as I finish that, I suture the uterine wound. After finishing that, I'll just see where I have made the injury, and I will close the bladder, sending the Foley's catheter, and by double sutures, and keep the catheter in situ for 14 days post-operatively. We'll inform the patient about the bladder injury to the attendants and the patient, and we'll also explain the risk to the patient. This is one of the serious complications during cesarean section, and it should be informed to the patient before starting the surgery.
Yes, that such a possibility exists. Now, please wait one moment. May I know who all are connected now so that I can ask them questions accordingly? One is Dr. Uma Maheshwari in the violet saree. Sunanda, I have asked already. I have also asked Shivani. And then I have asked Dr. Mary Genova ma'am, but she is not clearly audible. And then who else is there? Please talk. No one wants to talk. Dr. Manasa Shamla, yes. Yes. But who else is there? No one else? Uma Maheshwari, Manasa Shamla, Shivani. Okay, and Sunanda is there. So 1, 2, 3, 4 people. Only 4 are there. Very good. That's all? Right. So when bladder damage is there, less than 2 centimeters, we can go for a single layer suture with Pickle 30. If damage is more than 2 centimeters, repair in 2 layers with Pickle 20 or 30, either interrupted or continuous, with the first layer approximating the mucosa and second layer approximating the muscularis. However, appropriate mobilization of bladder is important. And as madam said, post-operative prolonged catheterization for 7 to 14 days. Okay, you have to individualize depending on the site and the extent of injury. Damage in the area of trigone can coexist with lesion of ureter and ureters, and need you may have to call the urologist. Next slide, please. Dr. Manasa, why are you lifting your hand? You have a point to make.
No, ma'am. Previously, you asked who else are there. So
Yeah, thank you. Please lower your hand. No, it's okay. I have identified you now. I know you're there. So this is a diagrammatic representation showing the mobilization of the bladder flap. Next slide, please. So adequate mobilization of the bladder is the key to minimize injury. And you must create a bladder flap at least 1 to 2 centimeters above the top edge of the bladder to minimize the risk. And as Sunanda said, we have to open by sharp dissection. Next slide. Right, case scenario. 5th gravida, previous 4 vaginal deliveries at a village PHC. She's had only 2 checkups so far. She has come to your hospital at 11 p.m. with 40 weeks of gestation. She's male, BP 140 by 94. Dehydration, she's also tired. Fetal heart sounds 100. CPG fundal height is 40 weeks. Pulse rate is 110. Distance. Per vagina, also is 9 centimeters. Station is +1. Capitis present. Thick meconium found on per vagina examination. Vulvar edema is also present. Will you take her straight away to OT or have a protocol for quick preoperative checkup, preparation, and check if C-section in second stage? What difficulties do you anticipate and your plans and approach to face these difficulties? So we'll have more than one person answering. Dr. Uma Maheshwari, your inputs first, please. Purple saree, ma'am. Manasa, please put your hand down, Amma.
Actually, she's a 6th gravida with the no proper checkup in any hospitals, and she has.
Dr. Manasa, right. Yeah, ma'am. Ma'am, please be loud, ma'am.
Yes, madam. Yes, madam. And she has come around 11 o'clock to our hospital.
Yes.
And we have to do a routine blood checkup.
Yeah.
Bleeding time, clotting time, urine,
We'll
and
decide for
everything. And if it's possible, we can do an ultrasound for the patient.
Yes.
I'll plan for emergency cesarean section.
Yes, madam.
We're expecting the
Very, madam.
Matching, madam.
Yes.
Everything with blood to IV lines, everything.
Yes.
The difficulty we expect is delivering the deeply engaged head.
Ma'am? Difficulty expected is?
It's a thick thing. We have to have a
delivering the deeply engaged head will be
Okay, you're done, ma'am. Very good.
Impacted.
And anything else to add?
We need a
Yes,
madam. We have to have a pediatrician whether we are going to say normal delivery. Pediatrician help is a must for this case, madam.
Madam, who is the lady in the blue mask below the chin? Are you?
Yeah.
I'll ask you questions. Yes, sir. It's okay. Next slide, please.
Hello?
Yes. May I know who is speaking, please? No. Yeah. So we need a quick preoperative checkup even for an emergency section. I think most of us
Yeah.
or
Yeah,
at
yeah,
least
ma'am.
the anesthesia team does it, right? So hemoglobin, blood typing and RH typing, hepatitis B, HIV, blood sugars. And of course, we do not really need shaving, catheterization under aseptic precautions, antacid prophylaxis, 15% mercury treated, preoperative hydration, adequate and not overloading, antibiotic prophylaxis within 20 minutes of incision. This was mentioned by Sadhana madam. And single dose broad spectrum first generation cephalosporin or penicillin from the cephalosporin or penicillin group. Now, what are the difficulties anticipated in this skin incision access? Because precautions while opening the abdomen, site of uterus incision, high, low, vertical transverse delivery of the baby, your surgical choices, and what factors guide you towards these choices. I think most of these have been covered already. Next slide, please. Again, these things have been covered. No. These. Yeah. So adequate length of the abdominal incision. I think this was discussed. No, you need it to be the size of a moderate Alice forceps. And open peritoneum high as in second stage, the bladder may be distended and it is really up. In obstructed labor, the lower uterine segment transition must be made a little high to avoid opening into the vagina. And a vertical skin incision gives you easy access to the upper part of the uterus, but makes access to the lower uterine segment difficult, especially in overweight women. And of course, as usual, we have to individualize the need. Next slide, please. Now, this is again a common situation. It is a 0 plus 1 plus 2 status with bonding station. I think uterus tightly grips the fetus with no space for the surgeon's hand, and the fetus is distressed. The fetus is also large, and the lower segment is thin, attenuated, and the bladder flap is up. What are your tips for safe, rapid, and easy delivery? Mary, madam, will you start, please? Mary Genova, madam.
Yeah. Yes, ma'am.
Yes, ma'am, please.
I'll take the bladder flap and lower segment.
Okay.
Incision. I see the shoulder in front, head is deeply engaged.
Okay.
I'll ask my assistant to stand with sterile gloves on.
Ma'am.
I'll ask her to push the head from below. I'll introduce the head inside and deliver out slowly the head.
So you want someone to push, ma'am, right?
Push, yes. Push technique. Otherwise, other technique pulling.
Yeah.
But both I'll try, ma'am. Both I'll do.
Both you'll try. Which one, if you were given a choice, which one did you try, ma'am? Okay. I'll stop anyway. So it has been shown from studies that the push technique is more morbid, causes more morbidities compared to the pull technique. Okay. So the lower incision.
Yeah,
yes, ma'am. Yes. So one can gently push the flat of the lower.
But I'm not.
Yes, ma'am.
Able to introduce my hand inside. I'll try pulling technique, ma'am.
No, ma'am. It has been shown that pulling method is better than the push method in studies. So you can also try vagina. No, previous slide.
Actually, the complication rate would be high with the push technique when compared to pull technique.
Yes, that's what I was saying. It is more morbid. And of course, you can also try the Patwardhan's technique.
And also, yeah, one thing I wanted to point it out, like actually when someone is pushing from below, the assistant should be adequately trained. They have to push with the palm of the hand, not with the fingers. And if they do that, they will injure the skull of the fetus.
Right?
Yes, exactly, ma'am. Exactly.
So we recently had a presentation by a postgraduates and they showed us some really nice videos. Next slide, please. So when pushing the fetal head up the vagina, try to flex the fetal head. If possible, use 3 or 4 fingers or a cupped hand or the palm of the hand to apply force spread widely across. Now this is the key, you should not put a focused force.
Pressure.
Spread your force. And it is important not to use pressure with 1 to 2 fingers. And a frog-leg position of the patient will help. Next slide, please. So Whitmore position increases the inlet dimension. Some people can also try IV nitroglycerin. And some people use Vectis. Next. So reverse breech extraction. The pull technique has lower uterine extension rates. Once the uterus has been opened, reach immediately to the peripheral leg like gentle traction. Pull the body of the fetus out of the uterus when giving traction parallel to the axis. This method is easier when there is adequate leg. Push technique takes longer time with greater blood loss. However, injuries are both same in both techniques. But again, as I have mentioned, studies show that the push technique causes more morbidity to the morbidity. Next. So this is another pull method. So place a palm on each shoulder, gently elevate them. There is also something called the fetal pillow. So this was shown, a video was shown by a postgraduate. You just put it's a sort of an inflatable bag. And once it is inflated, this is a push technique. It will push the fetal head around 3 to 4 centimeters. Next, you can also use a vacuum. So the risk factors for extension are occipital posterior position, it being a primary section, and the patient is in the advanced first or second stage of labor. Next slide, please. Patwardhan, I think most of us know what is Patwardhan. So when the back is anterior, one arm, opposite arm, trunk, one leg, other leg, and finally head. Modified Patwardhan, back is posterior, one arm, same side leg, buttock, other side leg, opposite arm, lastly head is delivered. And if the uterine incision needs to be extended anyway, we would like to have an extended J-shaped incision when compared to a inverted T incision. Next slide, please. So this was what I was talking about. We saw a video, we saw a demo video. So it is a fetal disimpacting system. So this was just placed above the pelvic floor. And once you do it, you just pushes it. And there is also something called the snorkeling. I didn't see this. This is something in theory. Next slide, please. So baby is delivered, suddenly field is full of blood. When you wish to start suturing the uterus, you find difficulty in tracking the uterine edge. Sunanda?
Yes.
Yeah.
Actually, yeah. Actually, when there is difficulty, first do not try to suture in haste. That inadvertently injure other structures like the bladder, ureter, or whatever it is. So always just try to devascularize the area.
Try to delineate, no? Try to delineate and
delineate and actually reduce the blood supply.
At the same time,
so
arrange for a transfusion, no? Ask the people to hurry and get the
resuscitate the patient first, and then go ahead, mop the area, and then if you are able to visualize after mopping, then fine. Otherwise, you have to cut short the blood supply, devascularize the uterus, so that you will be able to see the edges of the uterus. And we start doing with the uterine artery ligation.
But don't you think that you would like to suture the uterus first?
Yeah, definitely. But in case it is bleeding too much, and then if you're not able to see the edges, and probably put a pack, and then
we may not be able to see, we may be able to feel it.
But in something like placenta previa or
no, I was not looking to things like that.
Yeah.
So these are the points of concern. Yeah, carry on, Sunanda.
Yeah. We will try to suture the uterus, and in case you are able to control the bleeding, then you. Pardon?
Yes, ma'am. Carry on, ma'am. Yes.
Yeah. Suture the uterus.
No, Mary madam wanted to say something.
Okay, but someone is
audio is off. Madam, please speak. Mary Genova, madam. Okay, Sunanda, carry on.
So once you have sutured the uterus, you have to check for any other injuries, whether there is extension into the broad ligament, extension down into the vagina, or you have injured the bladder, or any other ureters are involved. And depending on that, you go ahead with the next step.
Okay. Right. Dr. Manasa Shyamla?
Yeah.
Dr. Mary, are you saying something, ma'am? Okay, Dr. Manasa Shyamla. You can read out the slide also. That's okay.
Caution before closing the uterus.
Yes.
Delineate the uterine muscle, bladder.
Yes.
Check the os and vagina to avoid stitching of posterior wall to anterior wall.
Yes.
Check the tear, extension, and meticulous repair. Preventive and curative measure of atonic and traumatic PPH. Meticulous hemostasis. Simultaneous tubal ligation to be considered with preoperative informed consent.
Right. Next slide, please. No. Previous section with anterior placenta previa. How will you place your incision over the uterus and how would you deliver the baby? And after delivery, placental bed starts bleeding. All of us anticipate this, right? So how will you deal with it? Dr. Manasa Shyamala, would you like to answer, Amma?
We can through the placenta, ma'am.
Yeah.
No.
Yeah.
And then?
Through and first deliver the baby, ma'am.
Yes. Then? Okay. Yes.
Caesarean in anterior placenta.
Just read it out. It's okay.
One should anticipate a poorly formed and vascular lower segment. After incision, fingers are insinuated in area free of placenta and uterine wall and membranes are ruptured. Fetal parts are accessed and delivered as per presentation.
Nanda, do you have anything to say? You raised your hand.
Yeah. What I wanted to say was like,
let her finish. Let her finish.
Yeah.
Cheppandi, Manasa.
When whole of anterior lower segment is covered with placenta, then placenta is incised and baby is delivered quickly through transplacental access. Use of prophylactic tranexamic acid, universal AMT cell can reduce placental bed bleeding. Warm pack, oxytocin, especially methylergometrin, uterine artery devascularization, and uterine tamponade are few effective measures for placental bed bleeding. Check on any bleeders carefully and ligate them meticulously.
Now, one thing is, I don't think any one of us is using methadone now. So, we have oxytocin, fine. Some people also have access to carbetocin. Yes, Sunanda?
What I was trying to tell, in case we can get a place wherein we can give incision avoiding the placenta, that would always be the best. If it is a little lateral, then
nice,
otherwise, or a vertical classical C-section, always cutting through a placenta, it is a little dangerous. And in case you cut through the placenta, you have to be very fast. Otherwise, there is always the risk of exsanguination of the baby. So always you have to be very fast.
But we have, unfortunately, I can't say I'm fortunate enough. Most often I've had to cut through the placenta. We didn't have a choice because the whole of central placenta previa just sits. It doesn't give you any chance. Yes. But then, as you said, you could go in. Again, we have to avoid the upper segment. At most cost, you have to avoid the upper segment. You'll have a lot of torture. So,
that is true.
Or try to find a plane where there is no placenta.
No placenta, that would be better in case, but anyway, you just have to take a call between
that
incising the placenta or a vertical section.
And we have to try our best to see for that space. Right? Unless you are running short of time and you do not find the space, then you have to cut through the placenta. Right. Next question. Patient is in the single person nursing home and while opening, he or she, the doctor, observes the surgeon rather, or the OBG, observes placenta accreta bulging through anterior wall involving the bladder. Query, that's a query. How do you suspect and identify adherent placenta on operation table and how do you deal with the situation? Dr. Uma Maheshwari, madam, are you there? Yes? Dr. Uma Maheshwari is in there. Is Dr. Mary Genova audible? Ma'am? Uma Maheshwari, madam, would you like to answer this question, please? You don't want to answer. So what would be your advice? Ma'am, please unmute yourself.
I
Yes.
Actually,
Mary
the patient
madam.
has.
Mary madam wants to say something.
Yeah. I'll deliver the baby first, ma'am.
Okay.
Arrange for blood, everything. Then we'll proceed with.
Ma'am, there's
Proceed with
nothing. There's
hysterectomy.
nothing in that nursing home. Not you. There's nothing. Okay, Mary madam. Any inputs, please? No. Shivani?
Some disturbance is there, ma'am. I'm not able to hear properly.
Oh, fine. No, ma'am. I'm okay. We are listening. Our voice is good to us. Mary madam. Yes, please carry on. Are you speaking? Right. Okay. Next slide. It's okay. Next slide. So single person. Now the advice anyone would give is just close it.
Just close it and shift the patient to a higher center.
Or any center which is better equipped. Always, always, always. Unless you have totally opened it, right? So if you have opened it anyway, you are knee deep or head deep or whatever. But in case you have time, if the patient is stable, pack her up and send her to a facility with better situations. I think that was the intention of raising this question, because many people do still operate. Next slide, please. So now here, distorted or distended lower uterine segment, blood vessel visible on the uterine serosa, placental invasion up to bladder or surrounding tissue. You have a strong suspicion of morbidly adherent placenta, and you're in your own 1 or 2% private maternity hospital on the emergency duty. What to do? Next slide, please. So delay the uterine incision. So the dilemma here is to tackle or to transfer. So if diagnosed before uterine incision, delay the uterine incision. Patients on part of the primary operative team is the key, and they should not proceed until circumstances are optimized. And it is very difficult for us to optimize the circumstances. Assess location and extent of placental invasion. If the patient is stable and facilities are not currently prepared, there's no bleeding, the maternal and the fetal status is stable and facility is again not prepared, send her. Cover uterus with warm laparotomy packs. Await assistance and supplies before proceeding to operative Caesarean steps. If there is no assistance ready at your place, close facial incision, place staples and skin, and consider transfer to tertiary care facility with experience in management of morbidly adherent placenta, especially percreta. And this is a life-saving situation. Now, recently in Kakinada, you're not that lucky anyway. Let's wait for a while. In Kakinada, we had a person with 2 previous sections. She came to us at 33 weeks of gestation, and she was referred to us from Rajahmundry, GSL Medical College, Rajahmundry. She was also very short and very obese, and she also had many missing teeth. And this lady had placenta percreta. So every day we used to get her in our dreams. We didn't want her to go into labor, but you never know, no? 33 weeks, she can go into labor anytime. So at exactly 37 weeks, we posted her for section. We got the blood bank ready. We got the urologist ready. We got everyone ready. And in spite of that, so we opened and we quickly delivered the baby by C-section. And then we proceeded towards hysterectomy, because that is the only thing you have to do, right? When there is a placenta percreta. But in spite of that, we just could not see anything. And there is not a single suture we did not try. We tried everything we tried. We did internally cardiac ligation also, the urologist was there. But it took such a long time even for that to control. And after 2 hours of struggling, she started to collapse. We have an excellent team here at Rangra Medical College, excellent anesthesia team. They were also struggling. They did not leave. And we pushed 11 bloods that day. And 4 or 5 or 6 maybe FFPs. And then again we had to call a surgeon. an experienced one. And what he did was, he simply de-roofed the ureters. He just pulled them apart, he put them to the side, and he closed it. And then she recovered. So if it is a nightmare to a tertiary referral center, just imagine how it will be in a person with a single facility nursing home. Next slide. So when placenta accreta has been disturbed and hemorrhaging, conservative measures are rarely effective. Delay may endanger the patient with massive hemorrhage, organ hypoperfusion, hypovolemia, metabolic acidosis, and coagulopathy. Next. So if the placenta accreta is realized before the uterine incision and the patient is bleeding, proceed to upper segment cesarean section, deliver the baby, and go towards hysterectomy. Concurrent mobilization of appropriate resources with ongoing hysterectomy in conjunction with the operating room nursing staff and anesthetic team, temporizing maneuvers, packing the abdomen, tranexamic acid infusion and transfusion with locally available products. Extra sets of instruments, quadrants, balloon catheter, and assistance. Next slide. So would anyone want to enumerate on the points here or at least mention them? Yes?
Yeah.
Sunanda, speak.
Yeah. Emergency hysterectomy in PAS. Consider extension of incision to Maillard or Chernies. That is like that will give more space for us to operate. Maillard is a muscle cutting incision, and they keep the patient warm. And because the spinal anesthesia effect will wane off, we will better convert her to general anesthesia and expeditiously and proceed with hysterectomy. And also
that is the problem we had. This patient is very short. We could not intubate in spite of having assessed all the situations. Yes, carry on. Tamponade device. I don't know. All these are not really useful once there is placenta percreta, right?
Actually, recently I was listening to one lecture of Dr. Piley. He was saying that that aortic clamp, the vascular clamp put for the aorta, that was a beautiful device which was devascularized the entire pelvis, and it has helped save a lot of patients. Probably we can try in
your future.
That is one aortic clamp.
Yes, we have to keep that in mind. And of course, in this particular case, we did internal iliac artery ligation also. And if not bleeding, leave placenta in situ, close hysterectomy, and perform a delayed hysterectomy. I think that's a dream situation. And this patient, she developed burst abdomen thrice.
Okay.
Don't ask. Just don't ask, She was not at all grateful also. Right.
Okay.
Next slide, please. So while opening up, you can see a significantly big myoma in the lower uterine segment and two interstitial myomas on the anterior wall of the upper uterine segment and one at the fundus. So, Manasa Shyamla, would you like to talk, or Mary Madam? Anyone?
Yeah, probably in this case, we would try to avoid the lower segment and go for a like classical cesarean section. That would be the best. And
just
deliver the baby and
they're very good. Sunanda.
We can manipulate and proceed.
Yes, ma'am.
Yeah, that's also one thing, but sometimes they bleed a lot.
We can try patient. However smaller, we can try anything.
Yeah, smaller we can try. Yes, but before delivery of the baby, sometimes is the bleed. Then again,
one we should not attempt, I feel.
Yeah, that actually only if they come in the way of the delivery, and if you're not able to deliver the baby, that is the only thing when you do myomectomy prior to delivering the baby. Otherwise, always deliver the baby and go ahead with myomectomy. That is always a safety.
Going and interfering with the stepping on a live wire. Yeah. Yes.
I have seen many myoma, a case with more than 10 myomas.
Yes, ma'am.
I found out a space in upper uterine segment. Found out a space in upper uterine segment, put the nick and deliver the baby as breech.
Yes.
And close.
Exactly, ma'am. So there is no need to interfere. Unless, as Sunanda says, they're very small or they're in your line of incision.
Incision, yes.
Right. Next. So this we have already discussed, no? And anyway, we have to individualize. So safe cesarean myomectomy, this is more of economic importance. Incision over myoma, enucleation, electrocautery to reduce blood loss, obliteration of dead space with 1 to 3 layers using interrupted delayed sutures. Suturing of overlying serosa, and in case of intramural myoma, current evidence discourages second incision on the uterus. Next slide, please. So patient with severe preeclampsia, section done after delivery of the baby, you have a uterine uterus with unstable vitals. So Dr. Manasa Shyamala, your inputs please, if you want to give any inputs.
Ma'am, try all the oxytocin, ma'am, cabatocin.
Yeah.
And tamponades, ma'am.
Yes.
Like first resuscitation.
Yes.
Arrange for the.
And one thing we have to remember in any case of preeclampsia is that the patient has already a contracted intravascular fluid volume, right? So you should not give overzealous administration or overcorrection. We always have to be careful while infusing fluids into her. Yes, carry on, Amma, please.
Yeah. Preventing and managing TPH in preeclampsia.
Yeah.
In preeclampsia, combo is complex and threatening. AMTSL and prophylactic administration of third stage of labor must be followed in all and PE women too. Average blood loss of labor may not be well tolerated by PA women due to hemoconcentration. Underlying endothelial dysfunction, hypertension, and use of magnesium sulfate and nifedipine make the mother more susceptible for PPH. Fluid management in case of PPH in PE women must be judicious. Recommendation is 80 ml per hour or 1 ml per kg per hour, as over-infusion can cause pulmonary edema.
And suppose you had pulmonary edema, what would be the most common presenting feature or embolism? This is just an off discussion. Yes, anyone?
Shortness of breath is called.
Amma?
Shortness of breath. No?
Yeah, very good. So once you have shortness of breath, you will suspect pulmonary edema and pulmonary embolism. And suppose it were a case of pulmonary embolism, what would your treatment consist of? This is clinic. It's asking as an academic question. Yeah.
Normal.
Yeah.
First, resuscitate the patient.
Yeah, resuscitate. But
and then actually the saturations are very low. You have to ventilate.
No, how do you manage pulmonary embolism? I want a specific answer.
You have to.
This is not related to OPG directly, and this is off the slides also. Okay, leave it anyway. Right. Shivani, could you just read this out, Amma? Preventing and managing postpartum hemorrhage in pulmonary in preeclampsia. Shivani isn't there. She's there. She doesn't want to read.
Unmute yourself.
Shivani.
Unmute yourself.
Yeah.
In preeclampsia with severe stages, coagulation abnormalities as a cause of PPH must be confirmed and excluded by the coagulation studies. Safe oxytocin and prostaglandin F2 alpha must be administered. Methyl ergometrin is contraindicated. Uterine massage, sequential use of oxytocics or the first line management. Compressions, sutures, and uterine tamponade second line measures. Selective vascularization can be done as per need. Appropriate clinical and point of care and lab tests should guide appropriate blood component therapy.
Right, thank you. Next slide, please. So C-section to be done for leaking at 32 weeks with severe oligamenous and transverse line. How to proceed? Incision in the uterus, delivery of baby, placental delivery. Dr. Uma Maheswari.
Madam, this is a very good question. We have to first plan where we are going to do the surgery. We have to have a good NICU setup when we do a surgery for a patient with 32 weeks uterus and leaking membrane and severe oligohydramnios. So we should have all the facilities. Mostly I give for a preference for where we have a good neonatal backup. So I'll give an incision most probably just above the lower uterus segment, and the baby should be delivered without any difficulty. Am I audible, madam?
Yes, ma'am. Please proceed.
So actually the delivery of the baby should be without any difficulty for the baby. So, and it should be cesarean section should be done, and the baby should be handed over to the pediatrician. Before that, I'll just check whether the steroids have been given to the patient, so that the lung maturity would have been attained. So
very nice.
Yes, madam.
Very nice.
Thank you, madam.
Very nicely summed up. Next slide, please.
Thank you, madam.
So here again. So would someone like to go over these points, please? Not for the sake of completion, but because someone reads it, it imprints better in our minds.
Uterus less distended, lower uterine segment not properly formed, myometrium thick and area over lower uterine segment small, LUS incision deeper, bloodier, inadequate, and hence can lacerate fetus or extend the uterine vessel. Due to small uterus, bowel may come into fail. Solution: adequate lower uterine segment incision and readiness to extend it, or U-shaped. Lower vertical incision can be choice too. Feel fetal back, raise and hold feet, carry out internal podalic motion and deliver as breech. If baby's hands come out, reposition it and raise back from shoulder. Preterm fetus with delicate bones and tissues, more prone to injury, and all maneuvers must be gentle. All maneuvers for breech, burn marshal, Marshall smell with, especially for after coming head, must be practiced.
Thank you so much. Yes, Sunanda, your hand isn't down.
Yeah. One thing I wanted to point out in trans is like a prior ultrasound is really helpful. You have to just sort out whether the back is like towards
Where
the
each
pelvis
thing
or back
is.
is towards the superior. So depending on that, you can plan your incision. So if
Very
it
good.
actually the back is superior, then it is easy to catch hold
Yes.
of the legs and then deliver it. But again, if
And
it
it
is
is
the back
very
is towards the
difficult to
pelvis,
extract anything once there is
yes,
oligamias. The uterus actually grips the baby like this. It's a preterm baby most of the time, and the lower segment is not formed. So this point is an excellent one, and I think it's not so difficult for any of us to have a pre-op ultrasound, right?
yes, ultrasound. Yes,
Not
that is
that
very
difficult.
helpful.
And it is something to be followed whenever you have cases of oligamias.
Yes.
Excellent point. Now please lower your hand. Sunanda.
Yeah, that's
So while you're finishing uterine closure, you see an enlarging hematoma at the lower segment going through the broad ligament. How do you deal with this situation, Shivani? Dr. Uma Maheswari wants to answer. Yes, ma'am. Carry on.
Yes, madam. In case of broad ligament hematoma, I'll just watch whether the hematoma is extending or not.
Very
so if
nice.
it's not
Or it is
extending,
going or not.
extending or not. So we can wait.
Extending, yes.
Yes, madam. And we can wait, and we can actually close the uterus if it doesn't extend, and we have to monitor the patient post-operatively.
Yeah.
If the broad ligament hematoma, if it extends, then we have to open it, and we have to try to close the bleeding points. Yes, madam. Yes, madam.
So what other thing
It will
is?
be a difficult situation, and we have to get blood ready for this patient, ma'am.
Yes, we have to be ready with blood anytime you plan a C-section.
Yes, ma'am.
But once you anticipate a difficult delivery, it is all the more important. Unfortunately, we had a patient, when I was doing night duties, we had a patient who came with impacted occipital posterior. She was in full dilatation, it was a priming. And there was no way that baby was going around, and she came to us. She came to us with full dilatation and an impacted occipital posterior. So I had to do a section. And while I pulled it, it had a lateral tear. So though I sutured the uterine artery, I had a huge broad ligament hematoma. I went on suturing, but somehow, okay, we pulled out the patient. But then we went for a post-operative ultrasound. So that showed a pseudo-aortic aneurysm. So things can be that bad. The best thing is to be ready and pray. Next, please. And of course, put a drain. Right, situation 11. 34-year-old primigravida conceived after IVF, known case of PCOS. Weight 110 kg, BP 150 over 100, and dependent retard 20 mg. Blood sugar ranges from 120 to 152. Controlled on diet, insulin 8 units morning, 6 at night. Posted for elective C-section. Ultrasound 37 weeks, mild poly, oblique lie, placenta grade 3, calcifications, Doppler of umbilical cord vessel, normal range. Estimated fetal weight 4 kgs. How do you plan C-section in such a case? And is it different or just a C-section? It is most definitely not just a C-section. So what would you like to do? Yes, ma'am. Uma Maheswari garu. You said you were going to say something. Chappandi, please.
Yes, madam. Yes, madam. Yes, madam. Actually, she's a case of PH and she's an IVF case.
Yeah.
So she has to be monitored. It's a case of mild hydramnios, and we have to, since her age is 34 and her blood sugar is normal, we can plan for a cesarean section.
Yes.
I'll wait up to 37 weeks, madam.
Yeah. Fine.
After 37 weeks, we can wait, madam. For complete 37 weeks, and at the time of 48 weeks, we can take for cesarean section.
So this is the way. So what are the issues here? Again, Mansa Shyamla usually comes to my rescue. Madam, will you please read this out, if you don't mind?
Worldwide prevalence of obesity more than doubled between 1980 to 2004. Okay. Issues: increased operative time, more blood loss, wound infection, and endometritis. Higher dose of antibiotic for surgical prophylaxis. Incision over abdominal wall beneath the paniculus is to be avoided so as to prevent wound infection.
So this is something which we have to remember. Yes, ma'am, please carry on.
A supraumbilical approach would give entry into uterus easily, but cosmetically not good. Lifting the paniculus by Montgomery strap and putting an incision just above pubic symphysis is cosmetically sound, but makes access to uterus difficult. Current evidence shows high transverse incision above paniculus after pulling down be most appropriate in obese women, which allows better exposure of lower segment compared to phenensteal, which takes longer time and more blood loss.
Next slide. Sunanda, any inputs here?
Yeah, first thing is like actually I wanted to add, when you're planning for such a morbidly obese patient, you have to have an extra 1 or 2 assistants. That is very, very important.
Definitely.
Very strong assistants. Strong assistant.
Strong instruments. Wide
strong
instruments.
instruments. Yes, yes, definitely.
Strong
And here,
pediatrician. Everyone is
yeah, here probably the landmarks like umbilicus and all, they may not hold so good. You have to
Will not hold good,
take your
yes.
ilia crest based on the bony landmarks like ilia crest and all.
Yes.
And as such, this patient has a very big baby, and probably extraction of the fetus may be difficult. You have to go ahead either with a forceps or a ventouse. That would be a better thing. Because it's a big baby, and pulling out the baby out of such a big abdomen may be difficult. And your hand sometimes, especially for those who have a small hand, the female gynecologist, sometimes it may be difficult.
Yes. No, it will be
forceps would give us a better hold of thing.
Yeah.
And we have to be vigilant about PPH. And in view of taking in consideration the depth of the abdomen in such an obese lady, everything would be difficult. Even if she develops some PPH or there is some extension of the incision, everything would be difficult. So
yeah, I feel that even our hand would be lost. Mine is a huge hand, but the average hand wouldn't make any difference to that size of abdomen. No, so we have to keep all these things in mind. Shivani, could you please read this out? Shivani?
Surgically extra retractors of different size, a must. Extra assistant will be of great help. Preoperative cephalic version can be considered. Version use of forceps, ventouse, breech extraction, or option if difficulty in delivery of the baby. Extravasation of the uterus is better. Vigilance for atopic PPH prophylactic treatment can be considered. Double careful for any sponge left by any assistant. Suction drying at the subcutaneous fat can be considered. Mechanical and pharmacological thromboprophylaxis can be considered in consultation with physician. Good and revised monitoring of the medication, insulin, and antihypertensive drugs.
Thank you. Next slide, please. I think we are coming to the end. Yeah, next slide. Right. So here is something like open up. Have you ever injured the bowel? Rare and yes, 0.8. So any feedback from anyone regarding bowel injuries? I think most of us are experts in causing bladder injuries, but bowel injuries are relatively rare and thankfully so, right? No one wants to injure the bowel. So what he says is that mild injuries of small and large bowel can be repaired by intestinal closure, but extensive injuries need dissection and multidisciplinary care. And almost always, nowadays, I don't think many people are injuring the bowel, right? So I'm going to the next one, please. Any issues in multifetal pregnancy? I don't know. Any inputs here from anyone?
Prior ultrasound is very important. Plan the method of delivery, and again how you want to deliver, incision and all those matter. Because like breech or transverse like cephalic, all those matters, and you have to plan
any
your setup.
non-cephalic in the first baby is an indication for section.
Yes,
But
yes.
There you have to see the maturity of the baby, right? You have to see for the lung maturity, and in case she doesn't go into preterm labor. So luckily today only we did a section, 37 weeks, both babies breech, and both were dichorionic and diamniotic. Second fetus is at the disadvantage, as after delivery of the first fetus, uterine contractions lead to reduction of placental perfusion. And a prompt delivery of the second fetus is always planned, and oxytocin infusion is started. This point is something we have to remember, but we do follow it, no, almost always. Soon after delivery of first baby, we have to reduce postpartum hemorrhage. Next. Is it over, Niharika?
I think it's done.
Yes, ma'am, it's the last 1 or 2 slides. That's it.
Yeah. Could we go through them?
Yes, ma'am. You want me to change it?
Yeah. This was the slide I wanted a lot. So I'm very happy that all the panelists were so very active. And I don't know how you felt this panel discussion was. And thanks a lot, Niharika, because my laptop didn't open at the last moment. All these slides were given by Dr. Sadhana Gupta. I definitely enjoyed it and hope you did too, in spite of the delay. So thanks a lot, and your inputs are most welcome.
I think we all wish Dr. Sadhana a very successful election campaign. So with that, I'll stop sharing my slides. It was a very wonderful panel, ma'am, Dr. Padmaja, ma'am. Very well moderated. Thank you for the panel.
Niharika. Actually, this was Niharika's thing, but she was very generous to ask me, and I jumped at the offer because I would get a chance to study something which we usually do. So I studied, and I'm glad I studied. And I'm also glad that my panelists answered so well, and they were so very proactive. Thank you, Dr. Sadhana. Thank you, Apurva.
Thank you so much to the moderator and to all the excellent panelists we had today. Saiti, I think Sadhana ma'am wanted us to play a video.
Yeah. Did she? Right.
Saiti, are you here? Saiti or Tolika, anyone from Shield? So before we play the video, I would like to officially thank all the esteemed faculty we had today, our key organizer, Dr. Sadhana Gupta, our chief guest, Dr. Nagraj, and the guest of honor, Dr. Revati. Our speakers, Dr. Vidya Thobi, Dr. Sadhana Gupta, and Dr. Niranjana, our esteemed chairpersons for all the 3 sessions. Thank you, Dr. Niharika, Dr. Sita Ramaraju, Dr. Radha Lakshmi, Dr. Doras, Dr. Vijay Kumar, Dr. Divakar, Dr. Purushottam, Dr. Lakshmi, and Dr. Vijay Lakshmi. Thank our moderator, Dr. Padmaja ma'am, for her excellent moderation and making it a very interactive and a wonderful panel. Thank you. Thanks to all our panelists, Dr. Sandhya, Dr. Manasa, Dr. Uma, Dr. Mary, Dr. Pungathoi, Dr. Jasmine, Dr. Vijayashri, Dr. Sunanda, Dr. Sivani, Dr. T.M. Swati, and Dr. Asmita. We thank the Shield members Sahiti and Tulika for their support, and also a big thanks to our viewers who gave us our time. Thank you, everyone. Thank you for the session. If Sahiti is here, we can play ma'am's video.
The slides were
Yes, ma'am.
explained.
Yes, ma'am.
So please wait.
Scan doctor
Is the video being played? Yeah, all right.
Officially closing the session for today. Thank you, everyone. Thank you, Dr. Niharika.
Thank you. Thank you, Dr. Apurva.